We'll put in a bit.
Absolutely.
Right. It's working a little too well.
The next one, I think. Still being used.
They're fast. If they catch me driving down the side of the road, it's like that will happen.
Oh, it's around the lake. I know. Student being over on that side. They based it up today.
Like I said, I am intimidated for signing up to present at lunch. I thought it was gonna be like. No.
Yeah, set the bar high.
We should have done it.
Why don't you make everyone comfortable?
It's gonna be good.
And not have a power.
I'm just intimidated. You know, an all-star from Baltimore, just got a smoke. Country boy from Darren. I keep looking for the packet.
Oh. I still put a password to this thing.
I better start
That's one
using it.
last password.
I didn't have a power cord that worked. It was my
There were emails.
feeds. No, I don't have.
Are they still uploading back to the website?
Yeah.
Thank you. Oh, great.
I'll be back.
Of course.
I'll put my call back when I.
Everyone. Yeah, right. It started. It's the reading portion of our ceremony. Good afternoon. Welcome to the May 16th, 2024 meeting of the Maryland Healthcare Commission. I want to welcome commissioners and members of the public. This meeting is a hybrid meeting. There are commissioners here in room 100 and additional commissioners participating by Zoom. The ground rules for a hybrid meeting will continue to apply. I will begin with a roll call. During the meeting, I'll ask commissioners and presenters to identify themselves before speaking so that commissioners and members of the public will know who is talking and will have the same knowledge as those of us here in room 100. All commissioners when unmuted may speak. The public and most staff should self-mute
No,
and
Brian,
may
I
not
don't.
speak unless recognized by the chair. I know, due to the possibility of background noise, I ask the commissioners and presenters to mute their electronic devices when they're not speaking. I'll also ask commissioners attending remotely to avoid putting substantive comments in the chat as it's difficult for those of us here in the room to see them. The MHCC posts documents that will be acted on or discussed at least a day in advance, so members of the public have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into a meetings by posting that information on the homepage of the commission's website and on our various social media channels. Now I'll go through the roll. First one is Commissioner Bandari, who I can see on the screen. Welcome.
Yeah.
Commissioner Blake, here in the room. And Commissioner Boyle is here. Commissioner Bazinski is here. Commissioner Cheatham,
Here.
welcome. And Commissioner Douglas is here. Welcome. Commissioner Gilroyd,
No, Commissioner Gilroy is on travel.
okay. Commissioner Gilmore. And Commissioner Jensen was here. I'll imagine stepping in a minute. Commissioner Ojikutu. Commissioner Spinner, welcome. Commissioner Stroughton Duncan. Commissioner Wang is here in the room. Welcome. And I see Commissioner Wood. I see you up there on the screen. Welcome. We have pretty full house. Thank you all for joining us. We have only one item on our consent agenda, approval of the minutes from the April 18th, 2024 Commission Public Meeting and Closed Sessions. The minutes for the closed sessions are confidential, and we ask the commission to keep them confidential. Does any commissioner wish to discuss any item in the minutes? Hearing none, is there any objection to adopting the consent agenda, which are the minutes? Very good. Commissioners received the written updates from our centers, their packets. Commissioners, do you have any questions on the written updates? None? Ben? Oh, go ahead, Commissioner Boyle.
What is, I'm trying to, 5 exemptions withdrawn. How was an exemption? What goes into that?
So on the exemption, let's see.
It's, Communicare Health Services.
So they had sought an exemption. They decided not to go through with the project that the exemption applied to. I think that's, the general explanation that
That, I mean, that makes sense, but I don't usually see that, so.
it's pretty rare that, because it's, even though an exemption is not as a broad as a commission review, it does require action on our part and action on their part. So typically, if someone goes forward with a CON or an exemption from CON request, which typically involves another type of project, they plan to go forward. In this case, Communicare decided not to proceed.
Question, and I think this will be done in the legislative update, but I'd love to know a little bit more about the prior authorization study. Will that be something you talked about?
Briefly about that, that's been an ongoing area of responsibility for the Healthcare Commission, and periodically that was a piece of legislation that was fiercely debated. So noted that perhaps a few more details when we get to that point regarding what we do. I want to add that study recommendations are already underway and the governor just signed the bill.
Ben? Thank you. Ben, do you have any updates not included in the monthly updates?
I have a few things, as I noted, the governor's, he saved the best to the last. This morning, he signed all of the bills that, or most of the bills that MHCC had worked on or monitored. I'll leave it to Tracy to explain those all to you. But I would note that I'll tick off the areas: trauma funding, nursing home acquisitions, utilization review, prior authorization, and a certain mandates that we worked on. Also passed related to breast and lung cancer screening and hearing aids, hearing aid coverage. You'll talk about many of those later on, but it was, I guess, if you look at passage of legislation that we supported, a pretty good legislative session. Kind of give you an idea of where I think the summer work is going to be for the commission staff. We are waiting for the announcement of federal government's decision on Maryland's participation in the AHEAD model, which would be the most likely the follow-on from the current model, the total cost of care model. The announcement is anticipated next week. I don't think that has changed at all. The commission, the state did get about 24 questions several weeks ago related to our initial response, that all those were submitted timely. And I think that there's a high degree of optimism that the state will be successful. Optimism also reflected in the fact that HSCRC has some procurements already posted for implementation support moving forward. A couple other areas that have been ongoing areas of interest over the last couple of years: the healthcare workforce. Again, a couple new work groups are being formed to look at more broadly the area of clinical workforce. Been a lot of interest in licensed providers, physicians, and other healthcare practitioners who must be licensed. I think we're now moving into non-licensed providers, community health workers, community behavioral health as well. So there's a broadening recognition that we have deficits, not just in the licensed categories, but in other categories of healthcare provider as well. Behavioral health, we'll be talking to you a little later in the meeting about what we're doing in one area of behavioral health. There are 3 or 4 different initiatives moving forward. There's a behavioral health commission focusing on access that is being convened by the department, and we'll be presenting on the 29th before that commission on what we are doing. And lastly, the entire area of reproductive health that David Sharp and his team, as well as our attorneys, have been working on for more than a year now. And the initial implementation date for that is June 1st, but we believe there's going to be much more of a gradual run out in implementation due to the challenges the technology vendors are facing in implementing requirements of the law. The happy news is that they are moving forward. The tension is that they're not moving forward, quite at the pace we had hoped, but everyone is pointing to technical challenges that are underway. Before I leave the legislative kind of front, I wanted to recognize a host of people who worked on the legislation. Tracy DeShields led that effort, but all the Senate directors, David Sharp, Teresa Lee, Ken Yates Trotman, and Winnie Hawk, all participated, and many of them testified before our committee, as well as the staff that works here did jump in and work on briefing documents, voting issues that needed to be resolved in draft legislation. So I want to recognize and thank everyone for their attendance this past session. It was, as I said, a pretty successful session if you count the number of important pieces of legislation that we focused on, and working with other stakeholders succeeded. Lastly, I wanted to note some personal achievements that I wanted to recognize today. We have had 2 individuals get their doctoral degrees in public health over the last 6 months. The first is Sumitra Buchanan, who works on Teresa's quality reporting, quality measurement and reporting team. She is our favorite blogger, maybe our only blogger, but she's also pursued a doctoral degree in public health from the University of South Florida. I don't think Sumitra is here today. If you can turn on your camera and wave to us, that would be great, Sumitra. But her doctorate was in strangely enough, using persona-based social media messaging to increase social engagement. Marylanders experience accessing nursing home quality data. Certainly right on point to what she does during her day job. Also today, I wanted to recognize Malet, we know her as Mahi, Kunjit Solomon, who received her doctorate from Indiana University in Public Health in Global Health Leadership. I didn't get her, after all of this, I didn't get the title of her dissertation. So help me out, Mahi.
I don't know if you can hear me, but.
We can hear you a little louder though.
Okay, so my dissertation topic was on aligning health information policies. Africa CDC, health exchange standards. So looking at, policy barriers. The opportunity.
Yeah, proof of that.
Portability and data center. It's a mouthful, but it was a very wording.
Bravo.
So congratulations to both of you. I think you might actually have a commissioner or two that could give you some advice, as likewise for Savitria as well. So feel free to reach out. Congratulations again. Back to you, Sheriff Sergeant.
So I think Melanie Cavalier has a new employee to introduce.
So, good afternoon, Chair Sargent and Commissioners. So it's my pleasure to introduce our newest colleague in the Center for Health Information Technology and Innovative Care Delivery, Mr. Makrid Benro. Makrid will be working as a program manager in the Innovative Care Delivery Division, focusing on value-based care initiatives and advancing clinicians' use of health IT. Makrid has a Master's of Science in Public Health and a certificate in Business Analytics and Data Science. So prior to joining MHCC, Makrid worked as a data analyst and project manager at Walter Reed Defense Health Agency. So please join me in welcoming.
Welcome.
Thank you, everyone. I'm really excited to be a part of this team, and I'm looking forward to contributing to the great work that we're doing here.
Thank you. Thank you. All right. Earlier this month, Leapfrog Group released the spring 2024 hospital safety report, and Ben shared with us Courtney Carter's report on the Leapfrog results. Courtney will briefly summarize the spring 2024 results. Courtney, on the floor.
Thank you. So as part of our public reporting initiative, we do track and monitor various hospital rankings and rating systems. And so the Leapfrog Group is one of those organizations that we pay attention to. And the Leapfrog Hospital Safety Grade assigns letter grades to hospitals based on performance of up to 30 patient safety and performance measures. And those grades are assigned twice annually, so once in the spring and once in the fall. So the spring 2024 grades were released last week. I wasn't able to get them into your written update, but we did want to give you a quick recap of the results. There was an almost even split. There were 13 hospitals that got an A, 13 that got a B, and 13 that got a C. And there was one hospital that received a D, and there were no F hospitals. I always like to point out, just for additional context, when Maryland began reporting or participating in this program in May of, or in the fall of 2017, only one hospital received an A. That placed us pretty low nationally. So we have come a long way. But based on the percentage of A hospitals this time around, we do rank 16th nationally. So that's up from 2 spots in the fall. And so when we look at state performance compared to national results, we do have more A's and more B's and fewer C's, D's, and F's. So we're pretty proud of the momentum and the trends that we've seen so far, and we will continue to update you. The next one will be in the fall. So that includes my updates. I'm happy to take any questions.
Commissioner Spinner.
Do you have a sense of where the hospitals are located that received a C?
Off the top of my head, no, but we have looked at, we've done some regional analysis and it's sort of spread out. We haven't found kind of any trends in that report. Okay, thank you.
Commissioner Boyle.
What do you attribute the improvement?
So that's a good question. So the grades take into account infection measures, patient safety indicators, hospital acquired conditions. And so with COVID, there was a big drop in a lot of these metrics. And then, so we're sort of seeing the opposite end now. I think there's a lot of emphasis on patient safety and improvement. And I think we're starting to see that kind of upstream.
I was gonna ask basically the question just in a little more, using my little word forms. Do we believe hospital quality has improved? I mean, obviously these measures, and these tests, right, have improved, but, and some hospitals have gone all the way from D to A, like it was really bad in 2017.
I mean, so this rating system only looked at these patient safety measures. So this is kind of a good gauge to see how we're performing in that area. So in terms of hospital quality as a whole, I don't know if I can necessarily say yes or no one way or another. It sort of depends on what area we're looking at. But I do think this is a good indicator that it's going in the right direction in terms of patient safety.
How much of an impact did COVID have on these ratings in prior years and this year?
It did have an impact, trending towards A's and B's, and then we went back to B's and C's, and we saw some more D's, and now we're kind of going the other way again. So we're definitely kind of seeing a little bit of an increase.
Is it possible that all we're seeing is just washing the COVID out of the numbers?
Maybe, but pre-COVID, we weren't doing that well. We weren't really doing that well as a state. So
It was surprising the first year, 2017, because we saw that the systems in Maryland as being very good, but then these particular
and
measures came back. And
typically what we find is that there are the star players, we see A's like several cycles in a row, and then similar with B's. So there's not a ton of change, but when we do, it tends to stay. When we do see that change, it tends to be consecutive.
Do you happen to remember, you said we're 16th, who's the top 1, 2, and 3?
I believe Utah is the top, based on A hospitals. I think they have 50%. I don't know what.
Okay, fair enough, thank you.
So who do the scoring or grading? Is this the independent organization or the patient or hospital send these surveys to the patients?
So it's an independent nonprofit organization, the Leapfrog Group, but they do use publicly available data from CMS. And then they also have a supplemental survey that they distribute to hospitals.
Then the hospital fill the paperwork.
Can you repeat that?
Hospital fill those surveys, right?
Yeah, it's a Leapfrog's designed survey that the hospitals complete.
Right. And you said Maryland is 16th. So is the other states are like smaller where they have less number of hospitals? What I'm trying to say, if the state is bigger, there are more hospitals, or the hospital is spread over a bigger state. Is the ranking is different in those? Does those?
So the rankings we have to just kind of take with a grain of salt, like with any of these hospital ratings. But the ranking is based on percentage of A hospitals. So theoretically, Utah, which is number 1, if they had 10 hospitals and 5 had an A and 5 had an F, and this is hypothetical, they could still be number 1. And then if another state had the same number of hospitals, but 8 A's and the rest F's, they would be number 2. So you kind of have to weigh it. But I still think that's what Leapfrog publishes. So that is what we report on.
It sounds like there might be some interest among the commissioners to hear a little bit deeper dive into the Leapfrog analysis reports, especially for some of our newer commissioners who won't have seen their annual reports every year.
And this was for the infection control only, or other parameters also?
It's a number of different patient safety measures. So it does include infections, but it also includes other preventable errors like ulcers, surgical complications, that kind of thing.
Got it. But they don't look at the patient quality of care. Because I'm surprised many hospitals, especially the area where I practice, the quality of care is going down. That's what I hear from the patients, but still they have a grading.
There is no consumer aspect of this. CMS does that, but Leapfrog doesn't incorporate those survey results in their measures.
Thank you.
So
Go ahead.
This is the, a bit of the history lesson, but it's probably noteworthy for the commissioners that, the reason we focus on Leapfrog is that we played a pretty significant role initially in getting Maryland hospitals participation because of the agreements that were made between Maryland and CMS. Historically meant that the data that Leapfrog needed to do their reporting was not available for Maryland for a long period of time, and employers would call us periodically and say, well, where are the Maryland hospitals? And it was because the data instruments that were needed could not be made available through CMS. But that same data was available through the HSCRC hospital discharge survey. Got that right? But that was not, quote unquote, the standard protocol for Leapfrog. So working with Leapfrog, along with HSCRC, we convinced, helped, encouraged them to add Maryland. We made the Maryland data available that was gathered in state, which was not the same as what CMS, not the same data instruments. Much of the same information was collected, but by HSCRC rather than through CMS. And they folded that in. The good news is now that CMS has included Maryland information in their collection initiative. So that's no longer necessary, but it was work that on the part of Teresa and her team that got this started back in the previous decade. I like to say that, previous decade, long time ago, but it continues to bear fruit, and we're continuing to be very interested in the progress. And a good sign, I may not have heard that, but Capital Region, which is been open for about 3 years, did graduate it, and its predecessor hospital, Dimensions, Prince George's Hospital Center, had never done better than a D rating. This cycle, they got a C. They got a C. So I thought that was progress. So
Thank you.
thank you.
Agenda item number 3 is a project change request. Conversion of Edward W. McCready Memorial Hospital to a freestanding medical facility. Maura Lawson will present a project change request for an exemption from certificates. Commission approved the original exemption request in January 2020 for the Tidal Health Peninsula Regional Medical Center to convert the Edward W. McCready Memorial Hospital to a freestanding medical facility. The final plan included building a new facility 3 miles from the existing hospital. Now Tidal Health Peninsula Regional seeks approval to continue to operate the FMF out of the original hospital building because the site chosen to build a new facility was found to be unsuitable. Program Manager and CON Analyst Maura Lawson will present the staff recommendation. Maura?
Thank you, Chairman Sargent. Good afternoon, Commissioners. So as the Chairman just said, in January 2020, the Commission approved an exemption from Certificate of Need to convert the Edward W. McCready Memorial Hospital to a freestanding medical facility, or an FMF. Project had 2 phases. In phase 1, the inpatient services of the hospital would be discontinued, and renovations would be made to the emergency department to create the FMF. The existing primary and specialty care services would remain available on the site. The original costs were estimated to be, for the renovation, $133,000. Phase 2 involved the construction of a new building on a site 3 miles from the existing hospital. The construction was to take 33 months, and the costs were estimated to be about $25.6 million. To date, renovations of the existing hospital necessary to implement phase 1 have been completed, and the FMF has been operational since March of 2020. Peninsula Regional is now requesting to continue to operate the FMF at the original hospital site for the foreseeable future. The original site was found to be unsuitable, and a new site has yet to be identified. As to financial impact, The project change reduces the total project cost from $25.7 million to $97,260. As phase two accounted for more than $25.6 million. In the original approval, McCready Health Pavilion was expected to have a net operating loss of $3.5 million per year after the third year of operation. It was going to be offset by Peninsula Regional's net income of $19 million. While the commission usually looks for financial feasibility in projects under its consideration, the rural location of the FMF and the vulnerable population were determining factors in the original approval. The current change request does not materially alter the expectation for a net operating loss, which will be covered by Peninsula Regional. As to this project change request, the commission has the following options under this review. They can approve the project change and incorporate the project changes into a modified exemption from CO. They can approve the proposed changes in part or with conditions. They can deny the proposed changes with explanation, or find that the proposed changes are of sufficient scope to warrant a complete review in accordance with the CON review process. Staff concludes that the project request is a permissible modification as it does not include material changes to the nature of the project or its immediate capacity. The requested change would not alter the findings the commission made in 2020 concerning the effective delivery of healthcare services to this population, public interest, and appropriate delivery of emergency care within the statewide emergency medical system. Staff recommends two conditions be placed on this change. First, that Peninsula Regional will submit a new application for certificate of need prior to finalizing any plans to relocate the FMF from its current location. And secondly, public informational hearings are an important requirement for approval of an FMF. And so staff recommends that the commission require the Peninsula Regional inform the commission and hold public information hearings at least 90 days prior to changing any services offered by the FMF. This hearing should address the plan for transitioning any healthcare services to be discontinued or relocated from the current site. From the applicant today are James Buck, who is the counsel for the applicant, and joining remotely is Chris Hall, VP of Strategy and Business Development for Tidal Health. Thank you very much, and I'll take questions.
Reading through some of the supporting documents, it seems that the new site was deemed unusable because of flooding issues and the cost of remediation for that. Current site seems to suffer from flooding issues as well, and they say at times it's inaccessible because of flooding. If I'm not, maybe I'm not reading.
It is on a peninsula. Okay, so it is sitting out on a peninsula. There are issues with that. The building itself has never flooded. It's more the parking lots that have had some issues.
My concern is that if this is a, emergency medical facility and, there's not many other resources in the area, the original project budget was much higher. If this flooding prevents emergency vehicles from bringing patients to the facility in a timely manner, it could cause delays or reroutes to much further away locations. That'll compromise patient care. I'm sure that the devil's in the details with this, but, would it be appropriate for this commission to say, granted, you don't have to spend $25 million on a new building, but perhaps remediate it so that you can have 24/7, 365 access and remediate some of the flooding issues, unless they're regional flooding issues on roads, which I guess would not be under the scope of this hospital.
I think that it's mostly roads, but I think it would help to bring in Peninsula Regional into this conversation. So I don't know if James or Chris would like to.
Great. Interested to hear what they have to say.
Chris, do you want to answer that one? Do you want me to?
I think you're on mute, Chris.
Sure, I can provide an update. So Thank you for allowing us to address this. So the hospital has been in existence since like 1920s. It's the roads that are leading to the facility that have had some flooding issues, mostly due to high tide or major storms that blow in. We use a local both National Guard, but also police to help transport any kind of staff or other providers that come in. The ambulances do get through. So it's nothing new. The city of Crisfield is also working with FEMA at this time to mitigate flooding across the entire city. So it's not just really where McCready is located, it's actually across the entire city of Crisfield. So there is some work being done on that.
I would add that even before McCready was converted to a freestanding medical facility, the bulk of the more extreme, more complicated emergency conditions were being diverted from McCready to Peninsula Regional or Atlantic General already. And so that's continued. The severity of or the acuity of the emergency department patients that are treated at the FMF are not as significant as
So currently the EMS system is using triage protocol to selectively bring less acute patients to this freestanding medical community. That be accurate?
Yeah, within FMFs, there is a limit to what they are allowed to serve. So the most severe patients normally do not, unless they need stabilization immediately. And then as soon as they are stabilized, they're brought up, but they're not really allowed to treat the most.
They certainly can and would be available in urgent circumstance to provide that level of stabilization. And then when there are these flooding events, Party arranges or Tidal Health Peninsula Regional arranges for the transfers of the patients that have included the Maryland National Guard, the Somerset County Sheriff's Office, the local police department, and in at least one case, the United States Coast Guard.
So I guess I'd be accurate in saying that within the scope of this project, there's nothing that could be done on the FMF facility that would eliminate the access issues due to flooding.
Sure, that's correct.
Okay, so it's more of a regional.
As Chris mentioned, McCready and Tidal Health Peninsula are involved with the flood mitigation efforts in Somerset.
Can you talk about the number of floods you've had, maybe a year or two? How many events have you had?
I think it's a few times a year. Chris, do you have any more specificity on that? I think there was the most recent one was in January, but it really has to do with the tide and wind that pushed water over this creek into the access road.
No, you're 100% correct. I don't have the count of how many times on an annual basis, but it's not as frequent.
Thank you.
McCready does arrange for, if there was a flooding event, they do arrange for transfer of staff and patients from outside the perimeter to the facility.
So, thank you. Where do you see this going? I mean, you already chose a site that you came to the commission and then, you know, it didn't work because of flooding. I kind of wonder why that wasn't known, but that's beside the point. Where have you looked forward to where you could build a site that wouldn't be affected by floods?
So I'll let Chris answer any type of planning, but I would say that because it is located on a peninsula, one restriction on the hospital conversion to a freestanding medical facility is that the FMF has to be located within 5 miles of where the hospital was originally located. And they basically lose out on half of that radius because it would be in the Chesapeake. I'll let Chris address any type of planning or future relocation.
Sure. As you can imagine, regulations change over the years and decades that I think the facility has been in existence. It was actually the Army Corps of Engineers that it's not so much the flooding, but the land being wet. Their request was to bring in about 6 feet of fill dirt across the 10-acre slot of land. And you can imagine that it's just untenable to get it to a proportion where it meets the requirements. So we are in conversation right now with the city of Chrisfield to discuss. We've had multiple meetings already with them, the citizens, just to talk about the needs of the community and what are alternative and options. But it's very early on, and the merger occurred in March of 20, and we lost over a year and a half with COVID, and that was the kind of a focus went away from looking at land and looking at sites for a year or two due to COVID, and focusing up here at Tidal Health Peninsula Regional in Salisbury and building out the COVID units.
So given the unique physical location of your hospital and the limitations inherent, would there be I don't know, a variance we could issue or permission to move beyond that 5-mile radius that would allow, because we're about patient access and about patient care here in this commission. And if there's something that's 6 miles away or a few other miles away that, would allow you to build a facility that would improve access and timeliness and less barriers, would that be something that would be beneficial? Is that I don't even know if that's within the purview of this commission to allow that.
So
as you're planning forward.
this current state health plan is written, FMF, it's created as a result of the conversion of a hospital, has to be located within that 5-mile radius. Pursuant to the proposed recommended decision by the commission staff, a CON would now be required to relocate the FMF. And it's my reading of the state health plan chapter that relocation would not have to be within that initial 5-mile radius. It could be relocated outside of that area. Requires.
I like it, Ken. We're to the Maryland Healthcare and Zoning Commission.
I just got the email. You're gonna accept them from the Army Corps of Engineers and that's. Go ahead, Ben.
So I thought it would be useful for just one person. I don't know if it's more or representatives from McCready to talk about, are the volumes sufficient to operate an FMF? That was a question that was raised at the time the initial FMF approval was issued. What have you found out, and how has that shaped your thinking, recognizing that there's no plan currently to do anything? But maybe Chris is the best person to answer that.
Sure. That currently right now we're running, I should say right after the merger, it's pretty consistent, somewhere between 10 to 14 patients a day are seen in the emergency room. We are keeping a track on the levels of severity of the patients that are arriving, whether they're at the higher level of severity or the lower level. As was mentioned earlier, there is no definitive care, backup care, so it is an emergency room without a cath lab or operating rooms behind it. So the more severe illnesses are transported and have been transported to Salisbury. So that is not any change. But we do keep an eye on the services. There, in those listening sessions I mentioned earlier, there are some items that have not been provided in that community that we have realized through both the community needs assessment, but also those fact-finding missions and conversations. A great example is pediatrics. There are no pediatricians down in Chrisfield. The closest one is within an FMF that has a facility in Pocomoke. So we're continuing to evaluate and continue to provide the services that are part of the FMF.
Commissioner Blake.
Thank you for sharing. I wanted to know a little bit more about your timeline. The timeline around how long you can estimate providing those services at the initial site, and then also a timeline that you could share about making that transition to whatever second site is identified.
Sure. As I mentioned earlier, we're in the conversations with the mayor of Chrisfield. We've continued those conversations. I can't give you an exact date saying within a calendar year X this will occur. There are active conversations occurring with the city mayor and the city council to talk about what services and locations of services, some of them regulated, some of it unregulated services. But at the end of the day, Tidal Health will be in Chrisfield providing medical care.
I would also note, for the benefit of the commissioners that may not be familiar with the original 2019 filing. But at the same time, it acquired Peninsula Regional, or I'm sorry, same time Tidal Health acquired McCready Hospital. Adjacent to it is a nursing home and a sort of a newer assisted living facility that are, I think, pretty full in terms of occupancy. So this is really part of a bigger campus to provide some of those services to the residents of those facilities.
Are there any other commissioners with questions?
This is Commissioner Bandari. Do you have any staffing issue here? Staffing, nurses, doctors? Because
No, luckily, we're part of, McCready is part of a department of Tidal Health Peninsula Regional. So being the largest provider on the Eastern Shore, close to a 300-bed medical center, we have the ability to share staff and making sure that we have the adequacy of coverage. Also, our emergency room physicians that are here in Salisbury are also signed the contract, and they are the ones providing care down in Chrisfield as well.
the reason I'm asking is Tidal Health itself in Salisbury has staffing issues.
Well, I don't think any hospital in the state of Maryland can say they don't. So we always are challenged. It's a rural community, so we kind of make sure we have it coverage.
Thank you.
I have a question for Maura. I take it we looked at, so the original plan was to move, that didn't pan out. So coming back for the modification, you've looked at this as if they had filed the original request and they weren't moving, and we've decided that that's fine.
I think that the most important thing is that these services continue on. I mean, what then would be the alternative to it? They are providing the services. Not only is there an emergency room open and operating in Chrisfield, but they also have all of these primary specialty care services that if the FMF were not there, I'm not sure that those would remain there.
So if the original plan had been, we're gonna convert, we're staying in the same spot, the recommendation at that time would have been, go ahead and approve.
I think that it probably would have been, and it would have been at such a lower cost at that time. I think that one of the big problems was the thought of building, sort of a 25-point-something million building for a small population. But this would have only been $100,000. I think that it's important to keep the care there.
Okay, thank you.
Yeah, just to be sure the commissioners are aware that last week we organized, spoke with Maura. I think you were on the call too. Were you on the call with the county health officer?
Was not on the call. So.
The two of us were on the call. We did talk with the county health officer in Somerset County, as well as Dr. Nilesh Kalirama, Deputy Secretary for Public Health and the department. And I think the county health officer did point out some advantages to having the FMF continue to operate at the McCready Hospital, which as James noted, the nursing home is still open and still, I don't know if it's a 5-star facility, but I want to say it's a pretty good facility. There's an even newer assisted living as part of that entire facility. And she was pointing out that the FMF there made it convenient for nursing home residents to have care. I don't think we had thought as much about that when the initial FMF was approved, but it is something to consider as we think about what the future of healthcare is in Somerset County. And don't be dissuaded that this is just a little bit of money. Every person's a data point on these issues, and it's challenging to access healthcare. Before McCready, a 3-bed hospital closed and converted to an FMF, I think it's safe to say it's still challenging today, with the commitment on Tidal's part to take significant people with higher acuity to Peninsula and treat those who can be treated in the community there. It's the poorest county in the state of Maryland. challenges about.
That makes sense. We did the discussion before motion, but I probably asked for, it. Do I have a motion to approve the project change requests, conversion of Edward W. McCready Memorial Hospital to an FMF? Got a motion? Do I have a second? Second from Commissioner Bazin. So as Commissioner Wang made the motion, just for the record. Are there any more questions or discussion? With that, all in favor? Say aye.
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 Are there any opposed? Great. Motion passed.
Thank you.
Thank you.
On behalf of Tidal Health, I'd just like to thank the commission staff and for thoughtful, careful analysis.
Thank you. And thank you for coming in to talk to us.
Yes. Careful on the peninsula. Thank you, sir.
Agenda item number 4, legislative wrap-up. Tracy DeShields, Director of Policy Development and External Affairs, will provide us with a legislative wrap-up. Legislative session ended on April 8th. We'll review the bills that were a priority for the BTC and the post-session obligations. Got the floor, Tracy.
Thank you. Good afternoon, everyone. Good to see you. So, as mentioned, I'll be providing a legislative wrap-up of the 2024 legislative session. Next slide, please. So, this was an interesting legislative session in that I think things started off relatively slowly. Sometimes that happens and then it sort of ramps up, but it seemed to ramp up more towards the end. I think everybody was sort of like, didn't really know how to describe the session because of how things were kind of flowing with regard to legislation and the committee's work during the legislative session. So there were about 3,400 bills total introduced between the House and the Senate. That also includes bond bills. Sometimes I include that. If you don't include it, it's about 2,700 plus bills that were introduced. And 1,052 actually were passed. And the governor is on track, I believe, to sign 100% of them. Usually, it's not usual, but I went back and I decided to do some research to see if governors actually signed all the bills that came in to that were introduced in it. And a number of them did actually at 100%. So meaning that you can allow a bill to go into effect without the governor's signature. Sometimes they do it when it's controversial, don't really like it or whatever. And Governor Moore is on track to be almost at 100%. Last session, he was at 99% signing the bills. And I think the bills that weren't signed were like 10. And then today, I don't know, I didn't count the bills, but there was a bill signing this morning. So the bills left to be signed were like 350. So we'll see whether or not he actually signed all 350. Some he'll do, the majority he does in a public session, the others he's just done without the public being present. So I just, an interesting fact, I think during Hogan's administration, especially his last 2 years, he was under 50% with regard to signing bills into law. He let the majority of them just go into law without a signature. So next slide, please. So certainly a big portion of the legislative session is dealing with the budget. Maryland does have some budget challenges for the upcoming fiscal year. They did pass a budget that's 63.1 billion for the fiscal year 2025. This budget does account for possible deficit of about 1.8% of the budget. It included 9.2 billion in operating funds for public schools, 906 million in capital funds for public school construction. And I believe this is all part of the blueprint plan that was passed a few years ago, or a year or two ago. An additional 127 million for local law enforcement. As you know, we're dealing with shortages there, so they had put in extra money. So it's not much, but it's an increase of 5 million from last year. And then 110 million to address affordable housing shortages and renters issues to try to prevent evictions and things like that. Also within the budget, there's 2.3 billion in the rainy day fund. However, that is a reduction of 9.4% from last year. And then it is projected that so the projected surplus at the end of this year was to be 696 million. However, that will decline to 110 million in the state's general fund.
So I don't understand the last sentence, but
So
I thought we were in a deficit.
yes, so the deficit is looking out towards the end of fiscal year 2025. That's where we're probably going to land. But right now, it looks like we have almost $1 billion or close to 696 million in a surplus. So, however, once the books close, that is going to decline to 110 million in the general fund. And part of that is also maybe related to a couple of emergencies that emerged at the end of the legislative session. Also, we're not getting, the revenue in is not the same as the revenue coming out, whereas in past years, we had more revenue coming in than was actually being spent. And then you have to also account for the end of federal government's emergency funding. So all of those things kind of play into what's going on with the deficit. Next slide, please. And I'll just mention a few things that were top of mind for the legislature and the governor. Certainly at the end of the legislative session, unexpectedly, we had the emergency with the Key Bridge. So they did pass legislation to provide emergency funding for port workers and employers at the port to sort of help cover salary losses and income losses there. Also, a big thing, obviously, with, I guess, concerns about increased violence, in particular gun violence. They established the Center for Firearm Violence and Prevention and Intervention, which would be within the Maryland Department of Health. And obviously, this is to look at the reduction of firearm violence, harm from firearm violence, and misuse of firearms. And then I think, interestingly enough, we passed, there was a bill that came out of judiciary and judicial proceedings in the Senate, and that is to allow for firearm manufacturers being sued in the event that their product is deemed to be harmful or marketed in such a way or used in a way that it caused significant harm. So they'll be able to sue firearms company, seller, manufacturer, etc. Next slide, please. And then some of, there were a number of bills looking to address equity. The governor's, the Enough Act, which is about engaging neighborhoods, organizations, units, governments, unions, governments, and households. It's a grant program. This year, it's a little low funding. It's about 15 million, but the idea here is to try to communities faced with really serious poverty issues can link with certain organizations, nonprofits, for-profits or whatever, and to try to address some of those issues in that community, but as a whole. So I think a lot of people were supported it. We're very excited about it. I think the majority of the governor's package actually did pass in this area. So I'm just like noting some of the more standout ones. Also, in the legislature, there was introduced a Senate joint resolution regarding affirming the Federal Equal Rights Amendment. On the federal level, this came about in 1972. It was never actually ratified to become the 28th Amendment, and Maryland and a number of states, I guess, were at the threshold where the president could sign something in asking Congress to ratify the Federal Equal Rights Amendment, the 28th Amendment. And so this resolution essentially asking the president to do that and kind of affirming it, and also asking other states that have not signed on to also move to ratify, moving towards the 28th Amendment. And obviously this is in light of women's rights or health rights in general, right? And then under protected health information, it's a bill that now adds gender affirming care under the statute that dealt with protecting reproductive rights information. So now this will be added to it. Next slide, please. And then with regard to reproductive rights, there was another bill that was introduced and also passed that would allow the health department to issue grants to abortion clinics for them to put in place security measures at those facilities if necessary. So, and then there were just a few other bills with regard to the governor's agenda dealing with victims compensation reform. The idea here is victims of crimes where they can probably get compensation of some sort. It can be fast tracked, which is great. There's the Renters' Rights Stabilization Act. Obviously the Maryland Road Worker Protection Act, and this is as a result to the horrific accident that happened on 695. And it also in addition to what occurred on the Key Bridge with the individuals that were doing work on the bridge when it went down. Also somewhat controversial, I guess, or there's a divide about it, and that is mental health assisted outpatient treatment programs. That bill passed. Also Critical Infrastructure Streamlining Act of 2024 and the Family to Serve Act. The last one deals with military members in the military and critical infrastructure, the idea being to sort of help businesses who want to grow or start up, to kind of help them to reduce some of the barriers, I guess, that could occur with regard, I don't know, paperwork, different sorts of permitting or things like that. They can kind of have a more efficient process for some of those things. Next slide, please. So now we're getting to us, MHCC. So our total budget appropriation for 2025 is $36,850,861,000, $36 million plus. That's our special fund appropriation. Included in that is $13 million for the trauma fund, and then $1 million in general funds, which we dole out to the Patient Safety Center under our requirement. So there are a couple things in addition this year to our budget, which is like a one-time, another $1 million, which will go to the Patient Safety Center. where they will, contract, pay the contractor who's going to do, healthcare workplace violence campaign. And, so we were able to, secure that for this year. We did try to lobby for that last year. It did not pass. This year it was more successful, which is great. And then, as you know, well, as I'll talk about when I get to it, we'll talk about the trauma fund. So I'll leave that for now. Now, in addition to the appropriation, there are a couple of budget actions that MHCC is going to be responsible for, or helping to participate in doing. So one would require us to do a report on private payer coverage of ambulatory surgical centers. And the issue there, I think, is sort of coverage, private pay, but also how, I guess, in particular, ambulatory surgical centers are included in a carrier's network, if you will. So we have that report to do. That report is due. We have an interim report that's due December 15th, 2024. And the final report is due June 1st, 2025. And then the next report, this is actually being spearheaded by the health department, but MHCC and HSCRC, we're to provide some information for them for that report, and it's related to the recruitment and retention of anesthesiologists in Maryland. In particular, concern there, I think, is with regard to reimbursement rates, Medicaid in particular, also, but also comparing that to Medicare payment, as well as the commercial market with regard to anesthesiologists. And then another report that we're being asked to collaborate with health department on deals with reimbursement of maternal fetal medicine. In particular, I think you're talking more, again, looking at Medicaid, but you're talking about like serious or complicated pregnancies where maybe you have to be in the hospital, or special tests have to be performed, procedures or whatever. So to look at the cost of that, I think predominantly, again, this also is probably associated with health disparities in particular, and trying to look at that within that population. And then lastly, HSCRC predominantly, in consultation with us, is asked to look at the implementation of the recommendations from the Commission to Study Trauma Center funding that MHCC, along with MIMS, spearheaded during the interim. And so the recommendations, so looking at that and to see how that work is going to be, what gets implemented or not. Next slide, please. So looking at trauma funding in particular, so this was kind of an interesting sort of thing because I've not really seen it before. But anyway, so we had there were two bills that were introduced, House Bill 1439, Senate Bill 1092. They are exactly alike, but they do focus, there's information where they focus on the Maryland Physicians Trauma Fund and some of the changes there, like how much, what we can look at with regard to reasonable compensation equivalents, how the level of the funding formula, if you will, for issuing grants and paying on-call costs, correct? Okay. And then, so those have been changed, and they changed accordingly. I think it's in a more positive direction. It also gives us flexibility with the Healthcare Cost Commission to increase or reduce depending on the amount of money that's actually in the fund. It also provides where we can give up to a $900,000 grant to Johns Hopkins Hospital, their pediatric center. They have a pediatric trauma center, as well as Children's National. For that, we are to adopt regulations in accordance with the changes that were done in the legislation. And then also come up with a process for awarding grants. Before, with regard to grants, it was just limited to equipment, and it could only be about 10% of the reserve left in the trauma fund. So it was very, very small. This actually allows us to expend almost up to, if we have 13 million and let's say we have 7.5 million left over, we could almost go up to about 10% of the balance of that, the revenue of the trauma fund with issuing grants. So it's much more meaningful if you're a trauma center, if you need something, you could actually perhaps fund it. And then each year we do this anyway, we're still required to do an annual report on the trauma fund. And I'll just note that this year, there's a Budget Reconciliation and Financing Act of 2024. This comes in every year, and it has different spending requirements as it relates to the budget. So the same budget language that's in House Bill 1439 and Senate Bill 1092 is also within the Budget Reconciliation Act. So just interesting. So, I mean, just notes that trauma was a big issue for the legislature this year. So, next slide, please. Also, this year, nursing homes. So, major bill that we worked on, and also, you know, we had the nursing home work group, acquisition work group over the interim. So this came out of that. So this bill now will allow MHCC to approve or deny an acquisition. So within 60 days of notice of an acquisition, a person or entity has to apply to the Healthcare Commission and for review. This allows for the executive director to do a review. He has only 45 days in which to complete the review, or he can refer it to the commission, and then there's the 60 days. It's not a new timeline. So if he took 10 days to get it to the commission, then you only have 52 approve it. So, and then also it provides for that there has to be a plan if an entity is purchased where they have rooms that have more than 2 beds in them, they have to provide a plan to the commission to reduce how they're going to reduce those beds, the number of rooms with multiple beds beyond 2 in those rooms, or they can also request a waiver for a limited period of time, but they still have to initially provide a plan to us on how they're going to do that. So we do have to adopt regulations by January 1st, 2025, coming up. And then, yes.
Could you clarify the 60 days again for me? Does that include the time that they have to submit their documentation and our time to review?
So the way it would work is once they have a completed application submitted to us, the timeline starts. Correct. Thank you. Because we talked about this before, like it had to, a lot of conversations before and during session. But yes, so the timeline really starts once we have all the information, a complete application.
Okay.
All the information submitted. Yeah, we wanted to make sure that was the case as well. And then the second bill was maternal health, dealt with maternal health. This predominantly, currently right now, providers who accept Medicaid payments for obstetrical care. Now they have to submit a prenatal risk assessment form, and it goes to the local health departments, and they review it. Right now, it's not mandated, but this bill actually now mandates that this be completed and submitted to the local health departments. And then MHCC, in collaboration with the health department, is to develop a report card. And the report card would include, with regard to the birthing facilities, like number of vaginal deliveries, C-sections.
I think Commissioner Boyle had a question.
Oh, okay.
It's great that they have to complete the assessment form, but how is it actionable? I mean, how does it truly impact better patient care?
I think the idea here is to really sort of track morbidity. So so the idea here is that they now have to participate in the severe maternal morbidity surveillance and review program. So I think the idea is if they start to see abnormalities or increased issues with births, be it, well, it doesn't mean that the baby that there has to be a death or anything like that. It's just that there are complications or there are issues. Then I think the idea would be the local health department would somehow figure out how to step in so that maybe there's more monitoring or there's or more care provided to the mother or patient. I'm not 100% sure, but the report card plays into the birthing facilities.
So would well, we're helping develop the report card, but would that report card then use that information to sort of shine a light on which facilities are doing well or poorly?
Definitely. I mean, that's the intent of the report card. Right. To a hospital performances. There's only one quote unquote birthing center in Maryland. They talk about birthing centers, they're really talking about hospitals that deliver babies. We don't have any freestanding birthing centers. They're trying to anticipate.
Okay, I was just wondering if having to fill that out, if that will then translate into a requirement to pay more attention to.
I think that's why they want to monitor it so that they have better information about exactly what is going on with regard to maternal child care. I mean, with maternity.
Is there penalties for not completing those, since it's, it's legislatively mandated? What's the consequence for a provider who doesn't?
I think there was a consequence associated with it.
Yeah, I'd have to go back and read that. I
don't think there was a consequence associated.
Financial penalty.
Right. So
These are Medicaid, so they have a contract with the state, so maybe
yes,
Medicaid is thinking about opposing.
Yeah,
Oh, that far, would they be able to then determine consequences since this is?
And it's Medicaid, yeah, it's limited to Medicaid reimbursements, if I'm reading the summary correctly, which means that maybe they could tie reimbursement to it. Or I don't know though, I'm speculating.
in the legislation, there were no penalties associated with it.
Are we looking at both maternal outcomes and infant outcomes in this assessment?
I believe so.
Okay.
Yes.
And this pre-assessment is supposed to be tied to
when they're like, once
they
they start
deliver.
doing prenatal appointments, they have to do it within, I think it's a short time frame of when they have their first appointment. At that first appointment, that's where, or the next appointment, they have to do the prenatal risk assessment.
This is a one-time assessment, or do they get reassessed throughout the mother's pregnancy?
I think the form that they fill out initially is just one time.
Okay.
I think that in terms of the report card, and how broadly it's cast is lead agency is within the Department of Health, the maternal and the Bureau of Maternal and Infant Health is the lead agency within MPH, and we would be working with them on the report card. The assessment and those types of activities are all falling.
Okay.
We can shape that report card a lot.
But I mentioned that the assessment form, prenatal assessment form.
That should come up, but I don't think people can hear you.
Have a seat.
The prenatal assessment form and the referral form, they're in place now. They're just hard copies, and they're trying to build an infrastructure so you have an automated database that the health departments can get and then see how well the assessments are being handled, where the referrals are going, and then kind of share that and build on the infrastructure to care for maternal patients. There is no, at one point, the bill had the reimbursement by Medicaid. If you, or you would not be reimbursed, or there'd be a penalty if you didn't fill out the form, but that was taken out. Right. So.
Question. For the assessment form, this is for the provider to fill out. Is there an assessment form for patients, the mothers or the birthing people who are receiving the the services?
Not in this bill. It's
Not in this bill, right? Okay.
A question, Commissioner?
No.
Thank you, Teresa.
Lisa's back.
Next slide.
Teresa.
So we do have a couple of well, mandate studies to do. One is related to the coverage for prosthetics. And in particular, the utilization of L codes and related codes within the all payer claim system. I think to look at whether or not, how it's covered and how that is being reimbursed.
What are L codes? And I realize this is a tough area because you get these bills and you have to become instant expert for that. If you know, it would help.
The L code is a specific CPT code that refers to a device.
That's the medical devices.
Yeah.
So,
Sync.
yes, so that's one. The bill actually passed, but they also, the legislature would like to get some information on sort of like what the reimbursements are like, payments for that. And then we did this House Bill 1137 dealing with coverage for calcium score testing. This has to do with like looking at your calcium levels within your heart. This bill did not pass, but we're being asked to do a mandate study on that to look at what the costs are associated with reimbursement for that. Next slide, please.
Quick question on that.
Sure.
If we're gonna do an assessment on that, these are the coronary calcium scores.
Right.
Sometimes those are used in place of like heart catheterizations and such. So if we're gonna look at the cost, there may be some cost savings from tests not done or procedures not done if this test is available.
That would be fairly within the scope of what we have to evaluate.
Right.
Do a mandate study, I believe, right?
Right, we would evaluate something to that effect.
We would include cost savings for procedures avoided, I think, in the normal course.
Okay.
Good point.
Yes. As I understand it, calcium scoring is sometimes important for people who have a high cholesterol, but there may be questions about, some unknown, perhaps genetic reason they're doing. There's not as much risk by doing calcium scoring. You can determine propensity or probability that there's blockage. If there's significant stenosis, and our friends in the interventional cardiology community get involved. But calcium scoring is a way to make a better judgment.
To risk stratify patients, whether through medication management or through CIM.
Next slide, please. So this one deals with health insurance utilization review revisions. In particular, this deals with prior authorizations. And bill would require carriers by July 1st, 2026 to basically have and maintain an online process for prior authorization, so almost in real time. MHCC has been tasked with 2 reports to do. MHCC, along with the Insurance Administration, to do a study on the development of standards for the implementation of payer programs to modify prior authorization. So essentially, they want a review of a literature review and a review of what other states have done with regard to implementing policies and procedures around prior authorizations. And included in that would be like approval rates from prior authorizations, ordering and prescribing patterns utilized for prior authorizations, and looking at also two-sided incentive arrangements or capitation programs, how they impact or participation in by providers of these particular programs. This report is due December 1st, 2024, so it has a very fast turnaround time. And with regard to prior authorizations, you're looking at prescribing medical care and maybe specialized care that healthcare provider says is needed by a patient.
Is the idea that the online is supposed to make it
faster?
Faster? Because I guess one question I have, like when I was running the Immune Deficiency Foundation, you know, we had patients, you know, rare disease patients across the country a lot of times requiring immunoglobulin replacement therapy or sometimes other very expensive therapies. So they're rare diseases, they're expensive therapies, and you have prior authorization immediately, they get turned down. And, you know, it's a real fight at times because they don't really understand these disorders. So is this kind of thing, if it's more streamlined, I mean, it sounds good.
But also, I think the idea is to also elevate, I guess, the healthcare providers authority when it comes to prescribing some of these like
that's good
specialized
to hear,
care.
because sometimes
That's really
it's
what they're
online and
trying
then
to
it
get
takes
to.
out,
Yes.
you know, some of the rare diseases and things that don't fit the more cookie cutter approaches.
So these are good questions. And what I would say is, think of it this way. Today, the process of prior authorization, seeking the approval, submitting the request is a bit disjointed. You know, carriers have oftentimes different strategies. So how the information is sent from the provider, if you were interviewing lots of different practices, they'd say, well, I can't keep pace with the changes because every carrier wants information differently. To your point, it would speed up the process by having a centralized method. It requires the carriers to connect to all the electronic health record systems out there in Maryland that are used by prescribers, the providers, and it also requires a process of expediting the review process. So it makes it more streamlined, timely. It's not an easy thing for carriers to do because it's enormous work to try to create using the NCPDP standards, the national standards, if you will, to integrate that with the electronic health record systems and e-prescribing solutions. So the carriers will have a pretty enormous challenge. And our role is to help sort of oversee, monitor, and report back. And I think when Tracy was mentioning the report due in December, that really is looking at what's going on nationally. Are there best practices? What can you learn? You hear a lot about Gold Card. You've probably heard of that when it comes to prior authorization. California is one state that's been involved with it. AHIP has been doing a lot of research on the states that are moving forward. So we'll be looking around the whole approach of implementing standards. And we're supposed to monitor in 2025 and report back to the legislature at the end of 2025 on the progress of implementation. So we're looking to create a plan with input from providers and some other stakeholders, carriers, that speaks to the monitoring steps and what that report at the end of 2025 will look like. It's a lot of work to do in a little time, both on the carrier side, because this has to be up and running by July of 2026. And it also has to link to real-time benefits for consumers to have access to alternative medications, a list of alternative medications, as well as out-of-pocket deductibles, co-insurance. I imagine the teams at Care First and other places now are going, oh my gosh, how are we going to get this done?
Well, if you look at the number of federal regulations that have come out in the last couple of months, there's a lot of that going on.
Oh, and speaking of regulation, it does have a requirement for the commission to develop regulations for providers to seek waiver from using prior authorizations.
I've heard that divorce doctors from fax machines.
That would be equivalent to the gold card type model where trusted providers get a gold card is allowing a trusted.
I'm gonna go to the left.
Permission to authorize services without prior.
Right.
Is this only for the medications or for the testing also?
So it's for prescriptions and medical services. So it's prescribing and services themselves.
So CAT scan, MRI, any kind of lab testing, special lab testing, that's a medical service.
Yes, so it would require authorization under a carrier's model or plan, then this just provides the infrastructure, the vehicle, facilitate that.
Thank
you. You get to the study part, there are two things to look for in prior authorizations that folks don't often think of, but one you see in cases of hospitalization where you're less likely to see a denial as much as requiring a prior auth. Let's say care team be aware that the person's in the hospital and dive in and help with managing the care. So it may see a very low denial rate, but the purpose in that case may not be to deny going into the hospital, but to activate a care team on the back end. And then the other thing to look for, because you see this tension, if you have a carrier that wants to work and help manage care, that a prior auth might start a discussion with a doctor that goes outside of the timelines, but is trying to get to like, what's the right care? And the carriers have to balance. The answer might be no, if you're just doing a prior auth and then they want to talk. And then, at some point you're like, yes, but there's a deadline. But there may be some in the back end, some intention there that's not just how can we say no to this, but we talking to the doctor, is this the right course of treatment? And shorter the deadlines, the less room there is for that. That's not necessarily a bad thing, but there's might be more going on there than just how do we get to know.
Point. Thank you.
Go ahead, Tracy.
Next slide, please. Thank you. So another study that we we're charged to doing or facilitating actually came out of result of House Bill 1388. This was really not a bill that MHCC necessarily weighed in on. However, we've been asked or actually directed in the legislation to contract with a private consultant to study in particular the effect of private equity on the healthcare market, in particular with private practice, the impact on the state's ability to meet goals and objectives under the total cost of care model. And yes, we know there's going to be a change. So we'll look at that in relation to that, the impact to address health disparities and various social determinants of healthcare, the payer mix for physician practices and groups who are owned and operated by private equity companies, the impact on hospitals and the acquisition of private practices. So been charged to do that.
We doing the veterinary professionals part?
Well, so the bill impacted both now, well, yes, sort of, but it impacted veterinarians as well as other healthcare providers.
Sorry. Please go ahead.
How does the FTC's ban on non-compete affect the work that's been done on this?
Well, that's part of that was part of the discussion with regard to this bill and the legislation. And so the feeling was that the FTC's banned or whatever, they felt that probably didn't go far enough, and they wanted state requirements or protections put in place as well. And I think there's a lag time, I guess, with when the FTC ban goes into effect.
Yeah, it's the FTC came out pretty late in the session. If it had come out earlier, it might have been shaped, but it's my understanding that the FTC their prohibition does not apply to nonprofits. And some of the biggest outcry from physicians here in Maryland has been related to the behavior of the hospital systems that now own a lot of physicians' practices, and consequently, let's say if I'm affiliated with Johns Hopkins, I'm a premier cardiac surgeon, and I go elsewhere, that non-compete could be controlling, as my understanding, the FTC would not. That FTC regulations would not cover that, but ours would. It's also important to say that the FTC's regulations are going to be rigorously challenged by different entities. I know the Chamber of Commerce and other organizations say they're going to fight.
There are actually 2 lawsuits in Texas that were filed, one of them by the Chamber of Commerce. And I'm assuming they'll seek an injunction before September, so probably should do our report with the idea that there may or may not be an effect. I think those may or may not take effect. I think September 5 is the.
But there's a lot of work across the country in different state legislatures that the trend is NDAs are probably going to go away. The question is when and how. FTC jumped the gun. Nobody really saw that coming, but.
And then lastly, the last study, it's not something we have to do, but the Department of Health is required to do, and that is to contract with an independent consultant to do a study on the HSCRC, MHCC, the Insurance Administration, and the Maryland Community Health Resources Commission. The idea being, I guess, looking at what we do, if there's any overlap or duplication of efforts and recommendations. And that report study is to be concluded by January 1st, 2026.
Can I ask on the private equity, are there
Yes.
particular, I know this has been an issue with a lot of physician practices. Are there particular parts of the healthcare space that we're looking at, or that we've been instructed to look at, or is it just?
I think it's sort of a broad brush, yes. From what I gathered during the bill hearing, there wasn't really a particular space where this is more prevalent than in any others. But, and it sounds like to me for veterinarians, it is a very problematic, I guess.
Yeah, the non-compete provisions of the bill and the uncodified section related to us, the private equity study, seem touching close to the single purpose requirement of legislation. I think this was that our study on private equity was they found a convenient host. They wanted this study. We were told that they wanted to do a study on market concentration. Initially, I was told it was going to be on private, just on commercial insurance, the concentration of the commercial insurance in Maryland, which, you know, I don't think is the biggest problem.
Hasn't changed much in the last 15
It's
years.
pretty, but it got broadened, but I don't think the host bill banning non-compete clauses and the private equity study that we're responsible for, you know, are only tangentially related. I think we will proceed with the private equity study, but I don't see us necessarily tying back to the non-compete. If there are more consolidations, there probably are more non-competes in the current environment, but I don't think that was, you know, the 5 requirements that we were required to address, which read like, I've used this analogy before, they read like graduate school essay exams. Questions, you know, what's the impact on total cost of care? What's the impact on private or on social or health equity programs? What's the impact on hospitals being able to contract with providers? They seem kind of like questions that you could write 100 pages on or give an answer in a paragraph, depending on how much time we have. But the odd thing is we're told to get a contractor. Most of the contractors in this space are actually engaged in private equity. So we're going to have to kind of figure this out because, you know, if you're dealing with private equity as a policy matter, you're probably dealing with entities that are interested in that are private equity companies, and you know, what's the legislature going to do if we, for example, hire blank's private equity firm to give us this assessment. They're consulting all the time with firms that want to do.
Well, and that was sort of what I was getting with my concern is you look at, I don't know, like standalone infusion centers, private equity focus across the country. You could write a huge paper about what's the impact on infusion of medical drugs through private equity ownership versus hospital outpatient department. But we haven't even got to like any of the other parts of the health system. So I was wondering how we break that up to make that useful, actionable information, because it may vary in its effects from service to service.
Well, I think that we are going to carve out the nursing home activities as separate, because in some ways,
right, very different from it.
Yeah, we're dealing with that. I kind of think we want to try to narrow it, focus on hospitals, physician practices, and perhaps some ancillary services that, you know, are the ASCs, of which the big hospital systems, Tenet, et cetera. UPMC own lots of ASCs, as well as United Healthcare owns a couple hundred ASCs around the country. So every little sector has its own little story.
Yeah.
And then lastly, next slide, please. This is just more an FYI. So the Healthcare Commission, by way of the executive director, is legislation passed creating a Maryland Emergency Department Wait Time Commission. And so this actually builds off of work group that was formulated at the end of last session in 2023. So we are a member of that commission. Hasn't, I don't think, been formally established yet, but stay tuned. And then Behavioral Health Advisory Council and Commission on Behavioral Health Treatment and Access. The commission, the Commission on Behavioral Health Care, Treatment, and Access was formulated last session. MACC is a member of that commission. The department felt they have another, an advisory council, which was related to Medicaid, And so they felt that some of the work for both of those, the commission and the advisory council sort of overlap. And for efficiency purposes and also continuity, felt that at this time it was best to kind of join them together. They'll still sort of be separate because the advisory council will continue on, but the commission part actually has an end date. I believe, and I believe it's either 2028, 2027, or 2028. But we are members of that, and the Commission on Behavioral Health Care, Treatment and Access has been meeting. I think we've only had like 4 meetings so far. I think it's been quarterly. So not much to report there. That's the end of my presentation. Next slide, please. So, and not the end, but the beginning. Next slide, please.
So
They're not gonna give it to you.
no, Mount Fuji for you. So we saw Mount Fuji in January. And now I'm seeing Mount Fuji again, but I did not see Mount Fuji during the session. Could you explain the presence or absence of Mount Fuji during it?
I second.
No.
Question, when you give testimony during the session, you do the same sort of last slide?
Yeah, you only have 2 minutes, barely that. So you really don't do a slide presentation.
I do have a question about the anesthesiologist study because most of these, somebody says study maternal morbidity. I know exactly what the problem is, what they want to study, right? Are there particular aspects we're supposed to look at with the anesthesiologist?
There's
Have a theory.
rule that
What did they tell us? I mean, did they say,
anesthesiologists
we want you to look
think
at
they
it?
are paid enough.
Is-
That's basically it. They think they're not paid enough.
Are we limited to looking at billing rates and billing codes and things like that? Or can we look broadly at the
Yes,
practice
so
of anesthesiology in Maryland and its impact on Marylanders?
And the use of non-competes.
Of barriers to entry to the
So-
practice of
right,
anesthesiology.
so part of the study does the report that they want. Is they do want information included with regard to the proportion of anesthesiologist patient mix in hospital settings and ambulatory surgery centers covered by public payers, the average commercial payment rate for anesthesiologists nationally and in Maryland, the average commercial payment rate for anesthesiologists compared to current Medicare and Medicaid reimbursement rates, a comparison of the average commercial payment rates for anesthesiologists and other physicians as a percentage of Medicare reimbursement rates. And then a comparison, and this is from the legislation, comparison of average commercial payment rates and Medicare and Medicaid reimbursement rates for pediatric anesthesiologists versus anesthesiologists serving as adults. A description of other compensation provided to anesthesiologists not included in reimbursement rates such as stipends. The number of anesthesiology groups, hospitals, ambulatory surge facilities, and any other settings where anesthesia is provided that have hired temporary or contractual staffing for anesthesiologists. Impacts of current commercial Medicare and Medicaid reimbursement rates for anesthesiologists on recruitment and retention. And then impacts of current commercial Medicare, Medicaid reimbursement rates for anesthesiologists on hospitals and other care settings, access to anesthesia services, and a description of challenges that Maryland and other states are facing in the procurement of anesthesiologist services related to provider acquisitions. It's a mouthful.
Might guess that came from the Maryland Society of Anesthesiologists. You might be right.
But I think, we've talked a lot about health equity and impact on the community. And I think in responding to that report, there are the things we definitely should answer because in the legislation, we have to answer them, but maybe we could probably think a little more broadly in what else we address in terms of equity in the community.
Right.
Access to the profession even.
And there's no discussion of nurse anesthetist in this?
No,
Well, I think we would,
You can include
during the
that,
study, I think we would talk about substitution.
right?
It seems anesthesiologists must have a strong lobbyist for this one. I think this is related to every physician, not just the anesthesiologist. I think it's more related to the primary care physician. I can tell you anesthesiologists are paid very, very well.
Yeah, report.
That's the report.
There. Good job.
And in,
I'm that right up here.
it's interesting, in our rural community, we're right next to West Virginia, and in West Virginia, nurse anesthetists can practice in a hospital without anesthesiologist supervision. Whereas in Maryland, it's codified that there must be anesthesiologist supervision of anesthetist.
Actually, that was actually raised
Yes.
related to another issue.
Was that the dental health issue?
Then it was,
And-
nobody said anything, right?
It would be unpopular with the
But
anesthesiologist.
certainly the nurse anesthetist did sort of like go, hey.
Well, I don't have an axe to grind against the anesthesiologist. I do think though, if we're gonna look at the area, we should look at it broadly. They're part of lens, so nurse anesthetist could well be part of that analysis.
There's probably more, at least in our hospital, more anesthesia is administered directly by the anesthetist than by the anesthesiologist.
And Ken, if correct me, these nurse anesthesiologists, they usually make 180 to 200,000.
I don't know what they make. I don't even try
I
to
can tell
ask.
you, I know the
I don't
number.
want to know.
Yeah, I know. I feel bad for you, my friend. You work.
He said he doesn't want to know.
It hurts. It hurts. Give me some laughing gas. It makes it all better.
We don't make enough.
Need to make more.
So,
We're souls.
all right, thank you, Tracy. Agenda item, I never did get an answer to my mouth question. Agenda item number 5, nursing home family experience of care survey results for 2023. Each year, the Center for Quality Measurement and Reporting conducts the nursing home family experience of care survey. Family members of Maryland nursing home residents are given the opportunity to express their feelings about the care their loved one receives. Stacy House, Chief of Long-Term Care and Health Plan Quality Initiatives, will share the results of the 2023 survey. Stacy, you have the floor.
Thank you. Good afternoon, commissioners. Next slide, please. So first, just a little bit of data, just a little bit of research on nursing home satisfaction. The evidence shows that people do desire data on consumer satisfaction regarding nursing homes, and satisfaction represents a unique dimension of quality for families and residents. And families and residents do want to contribute to and benefit from satisfaction surveys. And under the provisions of Health General Article 19-135D, MHCC is required to develop and implement a system to comparatively evaluate the quality of care and performance in nursing facilities on an objective basis. So that's what this survey is. To my knowledge, only 4 states mandate a satisfaction survey. So it's Maryland, Rhode Island, Minnesota, and Ohio. And Rhode Island's satisfaction scores have been decreasing over the last few years. Minnesota's were increasing for several years and then began decreasing. Ohio's have been decreasing over just the last few years. Our survey has been conducted for several years, and it has shown to be reliable and valid based on traditional statistical and research criteria. And the data to support that assertion is provided at the end of this presentation. I'm not going to go over that information, but if you're interested in the details, they are at the end of the presentation. Next slide, please. So this survey is designed to elicit levels of satisfaction with a loved one's care in Maryland nursing homes. We only survey long stay residents, and we define that as 100 or more days stay. We survey responsible parties. It's usually the emergency contact. It's usually a loved one or a family member. Sometimes it ends up being a friend or a neighbor. And then we take the results and we use them to evaluate the quality of care and performance of Maryland nursing homes. And then we take the data and we present it in a consumer-friendly way on the Maryland Quality Reporting site. You learned quite a bit about the Maryland Quality Reporting site in the last commission meeting. And the scores are used as one factor in the Maryland Medicaid Pay for Performance program and also in some CON reviews.
Stacy, why we have more than 100 days? Why not 50 days?
I'm sorry?
Why we have more than 100 days, long-term resident? Why not 50 days or 60 days? 100 is a very large number, you know. long-
That is in research, that is the typical number of days that's used to define a long stay resident. A short stay resident is usually defined as less than 100 days. So that's the number of days that was chosen.
Thank you.
Next slide, please. So our survey was first pilot tested in 2005. The first full administration was in 2007. And it's been administered almost yearly ever since. Next slide, please. Since 2018, we've made quite a few changes to try to make this the best survey possible. And in 2018, we did an analysis to try to address some information gaps that we detected. And we added 13 questions based on the information gaps that we detected. And we also started offering a Spanish language option. In 2020, we started offering an online and phone interview option. And we also added 3 general questions about COVID or the nursing home's response to COVID and one open-ended question. And in 2022, we added an incentive for completing the survey at the second round of survey completion. And then in 2023, this year, we removed the COVID questions because the responses were not changing to the questions. And we changed several things about the methodology. We asked for emails and started contacting loved ones by email and asking them to fill out the survey that way. And then the second contact was a letter asking them to fill out the survey by online by sending them a letter. And then the third contact, we sent them another letter asking them to fill it out online, but also we sent them a paper copy. And then the fourth contact was another letter asking them to fill it out online. And then a fifth contact, saying that was a phone call. And then, we moved the incentive up to the first round of survey completion.
Question.
Yes.
So we get the information from the nursing home. How do we get the information of the people we're contacting?
From the nursing home.
Do they give you everybody?
They are supposed to, yes.
You don't cherry pick?
They are required to give us a list of every single person that lives in the nursing home, as well as the date of admission, and then we choose the long stay ones.
And this is blinded information in terms of what the nursing home gets back, so they can't figure out that, I guess the respondent isn't going to be concerned that their responses are, come back to them.
It's aggregated, yes. Yes, correct. It's all completely confidential.
Right, so 2 questions. 1, what is the incentive? And 2, have you considered doing text updates or additional contacts? I see you have mail and letters and a phone call.
The incentive is a $5 online gift card. And we have not considered text updates just yet. We are just now starting this 5 different.
Okay.
And it actually, I'll show you in just 1 second that this was very effective.
Okay.
But did somebody else say something?
Are we pursuing the residents or the relatives of the residents?
The relatives. Somebody else say something? I'm sorry.
I have a question. So if we're pursuing the relative, are there any instances where a patient in nursing home may not have a family member that could fill it out on their behalf?
Yes, if there is no, we would try to find, sometimes it is a social worker, but if they truly have nobody, then unfortunately, they don't have anybody to fill it out. But an ombudsman that knows them well could fill it out. A social worker could fill it out. Anybody that knows them well, not somebody who works at the nursing home. And not somebody else who lives at the nursing home.
If they have the appropriate cognition, could they fill it out on their own?
This is a loved one survey. This is a family experience of care, not a resident. Next slide, please. So there are 218 nursing homes, and they're all required to participate, and all of them did. And then of the loved ones who we reached out to, we had a 39.6% response rate, which is an excellent response rate. And it's even more excellent when you consider the last couple of years, we only had a 32% response rate. So that's why I said that our extensive outreach was very, very effective this year. So we are very proud of the increased response rate this year. Next slide, please. So once we receive all of the data, we calculate it into 7 different domains. We have the staff and administration of the nursing homes, care provided to residents, food and meals, autonomy and resident rights, physical aspects of the nursing homes, activities and security and residents' personal rights. Next slide, please. Then we calculate 2 overall measures. There's the overall rating of the care received at the nursing home, the percent who definitely would and probably would recommend the nursing home. And then, as I mentioned before, there's the one open-ended question where we ask, what else would you like to share with us about your experiences with this nursing home? Next slide, please. We also divide the nursing homes into 4 different peer groups so that we can compare amongst themselves. The 4 peer groups are the region of the state, the size of the nursing home, the ownership type, and the payment source. Next slide, please. Okay, so now for the results. The first 7 lines on this table are the 7 domains that I just showed you. They are on a scale of 1 to 4, with 4 being the most optimal score. You can see that 5 out of the 7 are over a score of 3. So those would be very good scores. And then the 2 that don't quite reach a 3 are food and meals and activities. They're 2.8 and 2.9. They're quite close to 3. I would consider those good. So those scores are pretty good. And the second to last line is the overall rating of care received at the nursing home, which is a 7.3. That's on a scale of 1 to 10, with 10 being the most optimal score. So a 7.3 is, I would consider that good. And then 71% would definitely or probably recommend the nursing home. We're starting to move down into the okay range. Next slide, please. And since we've been conducting this study for several years, we can look at some trends. These are 3 of the 7 domains that I showed you a minute ago. The staff and administration and care provided to residents. If you look at those 2, you can see that the scores were a little bit higher a few years ago. There's a little bit of a dip. And then this year, the score came up a little bit. Food and meals is a little more stable. Look at next slide, please. And then you see a similar pattern for these 4 domains. The scores a couple of years ago, a little bit higher, slight dip, and then the score comes up just a little bit in 2023. I'm a little bit hopeful here that maybe we're going to see a new trend. We'll have to see I'll have to see when I come back next May. So maybe they'll start coming up a little bit again. Next slide, please. These are the 2 overall scores. And it's the same pattern, slightly higher scores a few years ago, small dip, then the score comes back up just a little bit this year. Next slide, please. These are the peer group comparisons. For all 7 domains, the overall rating and the percent who would recommend the nursing home, the state average score was significantly lower than the nursing home scores in Western Maryland, smaller homes, and not-for-profit homes. And we've seen that pattern since 2018. A new finding was that the state score was significantly lower than nursing homes who had a payment source of other. And alternatively, the state score was significantly.
What does that mean? Other?
Not Medicaid.
Oh, everybody but Medicaid.
Yes, so everybody else.
Got it.
Okay. The state score was significantly higher than nursing homes located in Southern Maryland, larger homes, and for-profit homes. And that pattern we have found since 2018 or 19. So these have been very steady findings. Next slide, please. These are the results of the open-ended question. So this is where people can just write in whatever they like that they feel like they couldn't say on the rest of the survey. And the contractor read the results, took the responses and put them into different categories and applied topics. And that's what this is. These are the topics. These are the most popular topics in order for what people said. And so the top ones are the most frequently stated items. So the most frequently stated thing was that the nursing home was unprepared to handle COVID and poor safety protocols. There was high staff turnover and it was understaffed. And they were overall satisfied and would recommend the nursing home. So if you read through these, you'll see that there is a mixture of both positive and negative comments. And we've found that for the last several years since we've had this write-in, both positive and negative comments.
And so these are just things family members observe and on their own, 11% said nursing home ownership changes were issues.
This is what they felt they wanted to write down off the top of their heads.
So the third one says overall satisfied would recommend, only 14% will recommend? Or was it 100% question? Because these are open-ended questions.
This is the open-ended question where it just said, what else do you want to tell us?
That meant that 14% of the people motivated enough to write down.
Yes.
So that means 86% probably were not motivated.
I think he might be confusing the two questions. The question that actually assesses satisfaction is the standalone question, Stacy.
Yes, so there's the actual question where we ask, would you recommend the nursing home? Are you overall satisfied? This is the question where we say, what else would you like to tell us? So these are the people who actually wrote down, I really love this nursing home. And then they were put into a category that says that they're overall satisfied. And so this is 14% of people who responded to this open-ended question. So it's not 14% of the overall respondents, it's 14% of people who decided to write something.
How many people actually decided to write something?
It's at the bottom, 2,808.
Percentage wise?
Of
like percentage of the people who actually completed the survey and the number of people who actually decided to actually complete this open-ended question.
Well, 2,808 wrote something down.
5,670.
So about a little half.
Yeah, approximately. Yeah, so about half people bothered to write something down.
Okay.
Next slide, please. We also like to examine some issues around health disparity. And we conducted a multivariate analysis to look at whether or not there were differences in satisfaction by race, payment source, or ownership type. Again, this is a multivariate analysis. If you're interested in the other covariates that went into this analysis, they are listed at the bottom of this slide. It's kind of small type. And what we found is that whites are significantly more satisfied than non-whites. And those in not-for-profit homes are significantly more satisfied than those in not-for-profit homes. I'm sorry, than those in for-profit homes. And we didn't find any differences in satisfaction levels between those paying with Medicaid versus those paying with private insurance. And these are the exact same findings we found last year.
When you say significantly on these ones, is this a calculation of statistical significance with p-values and everything?
Statistically significant differences. Yes. Next slide, please. So overall, there was some declines in satisfaction over the years, but then there was this brief stabilization in 2020. And then there was a nice little increase in 2023 that I'm really hoping is a brand new trend. Again, we will see next May if it continues. I hope that it does. And the writing comments have been a consistent mix of positive and negative. And all the results this year were in the good or very good range. Almost all of the results were in the good or very good range, which is an improvement from last year and the year before. So we're going to continue to share all of these results with the community and the nursing homes to encourage improvement. Next slide, please. So we engage in a lot of outreach activities. So we are going to share this information with the Department of Aging, and all of this data is shared with the nursing homes. Each nursing home gets an individualized report detailing all of their results, but it's all aggregated. It's so that they don't know who said what. It's all protected. And then the information is also put on our website so that the community can see how each nursing home is performing. And we also try to make sure that that as many people can participate in the survey as possible by reaching out as much as possible. We have 5 different ways to reach out to people. And then also we have the Spanish version, we have the online version, we have the phone outreach. And we also integrate multiple different types of data sources to inform data patterns and identify different ways that nursing homes can improve. And as you learned in the last commission meeting, we have lots of ways to increase awareness of our results and nursing homes by social media. And I have all of our handles on there. So if you haven't followed us, please do so. And we use print, TV, and digital ads. We have lots of printed materials. Again, if you need any more or new ones, we have some we can get to you. And we have educational webinars, we go to events and expos. We also just went to the Harford County Expo last week. So next slide, please. So before I finish, I just want to say thank you to Julie Beard for all her help with this. And of course, Market Decisions, they're the contractor on this survey, for all of their work on this.
Thank you. Are there any questions?
Yes.
Commissioner Jensen?
Do we have any ability to compare our performance to other states?
Yes, I tried to do that each year before I come to this meeting. Unfortunately, none of the other states were ready for 2023 just yet. So all I had was the increasing, decreasing so far for up to 2022. Their data wasn't ready for 2023.
Would we be able to get that information before next May?
For 2023? Yes, for 2023, yes.
And then
I'll try to get 2024 as well, if it's ready.
just the other follow-up question is, so the overall approval rating was what, 72, 73?
The would recommend was 71%.
How do we determine that that's okay? Seems low to me.
Well, it's still, because compared to the other 3 states that do this, it's similar, but theirs are sometimes higher and sometimes lower. So that's how I gauged it.
Follow up to that. Are there any plans to follow up with those who wrote in for the open-ended questions, like follow-up interviews between now and next year?
We only follow up with the ones who indicate that there was a serious problem, to encourage them to report a serious issue, like with OHCQ.
But there's no plans to follow up with those who are satisfied or just wrote a comment to see, to do a little deeper.
There's no immediate plans to do that. No.
Any other questions?
Just a point for Stacy. Who else uses the survey?
Uses the survey or the data?
Government agencies, what other government agencies use the survey?
The Ombudsman uses the survey, and the Department of Aging, and the Medicaid uses the survey.
Medicaid.
Pay for performance.
They need that, they need annual results.
They use the annual results in their pay for performance calculations. It's 30% of the pay for performance calculation.
Just for our own thinking, I'd like us to consider possibly expecting better than in the 70s as a good or acceptable score. There's people that do better. My kid brought home a 70. I wouldn't be too bad.
On the other hand, have you seen the ratings for Congress?
Yeah. Not really applicable.
No.
So can you say anything more about the 71%? Is that what's the distribution of that score over the entire industry?
It's a very wide distribution. It goes all the way, I think the lowest is 30% and the highest is 100%.
So focusing on the lowest ones would be the way to.
That's
bring
what I
average
would
up.
suggest.
Yes.
Is to pick, rather than pick the average would be a lot to lift up. It's
Yes.
truly, the average, which Stacy and I'll have debates about this.
100% is great.
But I think that, the
And-
bottom quartile or the bottom 25%, 50%, something like that would be appropriate for what Commissioner Jensen recommends.
Well, and that's the conversation that I want to suggest we had offline. But if if the average is 70, there's work that can be done in there, and then you can dig into it. Figure out what kind of work and where, but I just kind of hate to think that we said, oh, 71's okay, now we're just good.
Thank you. Agenda item number 7. All right, skipped ahead. Agenda item number 6. Commissioner Douglas is a better estimator of mission timing than I am.
Skip me.
MHCC's oversight of cardiac services and what comes next. Winnie Hawk, Director of the Center for Healthcare Facilities Planning and Development, with assistance from Ben Steffen, will present an overview of the Commission's historical role in the regulation and oversight of cardiac services in the state of Maryland. Winnie, you have the floor.
Well, good afternoon to Mr. Chairman and Commissioners. Thank you so much for being here. It looks like this is the day for getting historical overviews of different things. So this is this presentation really was developed as after last month's meeting and the action items that the commission dealt with that related to the certificates of ongoing performance. And then the discussion about the focus reviews. We thought it was a good idea to provide the commission with an overview of how, sort of like, we're gonna start big and just like funnel down to how we got here. And also, since I haven't been at the commission for all of this ongoing evolution, is essentially, I may defer to Ben or have him jump in occasionally. So on that, we'll just jump right in. Next slide, please. First, I'm going to walk through the various state agencies involved in the oversight of cardiac services. Next slide. So the commission, our primary, we have direct oversight over cardiac surgery and PCI vis-a-vis the Certificate of Need program. The Office of Healthcare Quality, they are the licensing body. Health Services Cost Review Commission, they set the rates. And then MEMS, the Maryland Institute for Emergency Medical Services Systems, they coordinate emergency medical services, and they designate and evaluate cardiac interventional centers. And that's a designation that essentially it's part of their specialty and trauma referral centers. And they have their own standards. And so to get in their system, and most of the hospitals that have PCI and elective PCI are part of this system. Next slide, please. Starting with cardiac surgery, or in the olden days, it was called open heart surgery and CABG. So obviously that's when they crack your chest open, essentially, and put you on a heart-lung bypass machine. And again, I have a footnote here because before 2012, cardiac open heart surgery was the reference, and it would change to cardiac surgery to reflect current terminology. So federal law, let me just go back. So back in 1974, to eliminate unnecessary duplication of facilities and equipment, we instituted the Certificate of Need programs. When federal law expired in 1986 and they eliminated federal funding in 1987, Maryland continued.
to operate its CON program. So as of July 1st, 1988, a CON is required before establishing a new open heart surgery program. Again, that was the old vernacular. It's now cardiac surgery. And so at that point, approvals, at that point, I think when the CON program was first initiated, there were four hospitals, and I think that's on another slide. But as of today, we have 11 open heart surgery cardiac surgical hospitals. The most recent were approved in 2005, which was Suburban, and 2017 for Anne Arundel Luminous Health. So there's a lot of factors that have been influencing whether or not a new cardiac surgical program should be added. And the factors such as clinical advances, technological and demographic changes, all of those factors impact the need assessment. Next slide, please. So along with, wait.
I think we went up to.
This the slide. You go back, yeah, okay. This is about PCI, percutaneous coronary intervention, and essentially that's the treatment of a narrowing artery or stenosis, and that is, there's two types. There's primary, which is essentially an emergency PCI, and that's unscheduled, and that is currently performed in all 24 of Maryland's 43 acute general hospitals. And then an elective PCI is essentially a scheduled procedure, and that is essentially done proactively by when diagnosed by a cardiologist. So again, as I said, 11 of the 24 hospitals provide PCI, and 11 of those have cardiac surgery. Next slide, please. Now, this is sort of just going to walk you through the timeline. In 1980 was when the first state health plan was adopted, and there were 4 open heart surgery hospitals in Maryland at that time: Washington Adventist, Johns Hopkins, Sinai, and University of Maryland. In 1995, the regulations at the time required co-location. You could not do PCI at a hospital that did not have open heart surgery, backup cardiac surgery. So in 1996, what was called the Seaport Study, the Atlantic Cardiovascular Patient Outcomes Research Team, that was approved, and there were 9, I think, I actually don't know how many hospitals, I think 6 were in that initial Seaport study. By 1999, 9 hospitals had either CON, this is their open heart, but we had 9, and that was, we had the first 4, and then added to those other 4 was Prince George's, which is now University of Maryland Cap Region. We have St. Joe's, Union Memorial, Peninsula, and Sacred Heart. So by 2000, the Seaport study results came through. Oh, here we go. There were 6 hospitals in that study. They were Holy Cross, Shady Grove, Suburban, Hopkins Bayview, St. Agnes, and Easton. As a result of that study, in 2004, the guidelines were changed, and at that point, they were allowing primary PCI at hospitals without cardiac surgery on site. To implement that, the commission then began to issue waivers from the co-location requirement of having cardiac surgery as a result of the Seaport study. By 2009, there was another follow-up study, and this was to look at elective PCI without surgical backup. So what was happening is more experience was gained and better techniques evolved, and risks declined and results improved. They were looking to open it up further. Next slide.
And just to interject here, I think that the Seaport study did show that there were equivalent outcomes for emergency PCI in hospitals with and without cardiac surgery backup. But after that finding was implemented, if you will, there was a recognition that hospitals that only were approved to do emergency PCI, that is on patients that were suffering from a heart attack, there just wasn't enough volume by itself. And that was the trigger, one of the triggering mechanisms for the next Seaport E. Go ahead.
Okay, no, it was a progression. I think they found that allowing it without cardiac surgery on site did have better outcomes or equivalent outcomes. So
It's
here,
restricted to emergencies because you wouldn't have enough cases to be able to
right,
make confident.
yeah. So,
And that volume requirement was related to competency and not to finance, as to our earlier discussion with the commissioner.
yeah, I think there was always, the mantra I always heard was volume equates to quality. The more you do, the better you are.
Yep.
So then in 2012, the second Seaport study concluded. And what you have here is Dr. Aversano, who was in charge at the time. He found that PCI performed at hospitals without on-site cardiac surgery was non-inferior to PCI performed at hospitals with on-site with respect to mortality at 6 weeks and major adverse events. So with the conclusion of, at the end of the Seaport studies, what happened is Maryland hospitals then could not perform, they could no longer perform PCI without new legislation. So 2012 legislation was introduced, House Bill 1141, and that directed the commission to adopt regulations for oversight of PCI. And here's a quick summary of that, but we'll talk about that a little further because there were other events that triggered, next slide, please. There were other events that triggered sort of the culmination. It wasn't only the conclusion of the Seaport studies, but at the time, there were 2 high-profile stenting cases in Maryland, and some of the lawyers in here may remember those, but they were deemed to be the result of inadequate oversight and reviews. And in fact, at the time, I had just started working for the Board of Physicians in 2011, and that was when at least one of the most notable cases, they pulled his license in 2011. I double-checked; they still haven't restored this physician's license. And there was this, they were unnecessary stents being put into patients. So given the lack of oversight there and the Seaport studies, the 2012 legislation was passed. So what did that do? We had to adopt guidelines. They wanted the commission to create new mechanisms of oversight. And that is where we get to certificates of conformance and certificates of ongoing performance, the requirements for peer review and independent review. And then it also established a clinical advisory group to advise the commission and provide guidance on what the appropriate standards would be. So at that point, any hospital proposing, this last bullet, any hospital proposing to provide PCI needed to obtain a certificate of conformance, and thereafter, they were subject to the review of ongoing performance to maintain that ability to provide the service. And this was a departure in some sense from the traditional approach used in certificate of need, in that it was an ongoing, we issue a certificate of need and they implement the project, we issue first use and our oversight is done. So this is a little different because they come back and it's increments of up to 5 years is for the certificates of ongoing performance. And that's what you were dealing with last month. So next slide, please. So this is just a quick overview of the state health plan. I mean, for evaluating the PCI services in Maryland. Again, the max is 8 years. We look at data, quality, outcomes, physician resources. There are volume standards. Then at the end of the approval period, the hospital has to continue to meet these ongoing regulatory requirements, and that's the certificate of ongoing performance. But in between, so one of the things we were talking about last time, in between the certificate of ongoing performance renewals, if a hospital it comes to the attention of the staff that they're out of compliance, then we have the authority to conduct a focused review. And that's what I think we discussed that last month. So if the focus review identifies a problem, there's a plan of correction, there's a certain time frame, within which to come into compliance, and if they don't submit a plan of correction and address the deficiencies, then they've agreed. I think there was legislation, so subsequent to 2012 legislation, and I had too many slides already, but there was 2014 legislation, and if you are not meeting those standards, then you have to voluntarily relinquish your authority to perform the cardiac surgery or emergency or primary PCI. That was a departure because I think historically, there was no way to take away, or if they weren't meeting the volume standards, or remove the authority. So that happened in 2014. Next slide, please. This next slide is just a summary of it. It shows you the planning. Please go back. Nope. Next one. Yeah, thank you. So this shows you the 4 planning regions. All our state health plan chapters have planning regions. The number of acute care hospitals in each region. We have 43 acute care hospitals, those that have cardiac surgery in each region, primary, elective, and then the cardiac interventional center. I'm happy I have a list of all these hospitals. Each individual hospital, if you'd like, I'm happy to send that to you. Next slide, please. So as we sort of.
Can we go back to that?
Sure.
Second. Well, there's 43 acute care hospitals, right? 11 do cardiac surgery, and then for primary, elective, and intervention centers, so there's some overlap in those last 3 numbers in, is that correct?
Yes, those are the same 24. There's 23 of the 24. There's only one that doesn't do, of the 24 that doesn't do elective. And they are all designated cardiac interventional centers by MEMS.
Thanks.
Yeah. So next slide, please. Now we're finally down.
Holy Cross is the one exception, correct?
Yes, it is Holy Cross. So what's next? Next slide. So as as the hospitals have always had cardiac surgery volume requirements, and they also have PCI requirements. Now, the volume requirements for cardiac surgery are for the facility, not necessarily the practitioner. PCI, it's both for it's for the facility and the practitioner. So as a result of our certificate of need and certificates of ongoing performance, hospitals, they have to maintain volume requirements. And so, as I said, PCI as well as for cardiac surgery. The new cardiac surgery programs now have to commit to doing 200 cardiac surgeries by the 2nd year. That's for adults.
Is there any mechanism for adjusting these volume requirements based on new data? My guess is there's constantly data coming out on what's an appropriate volume level to maintain competency. It might go up, it might go down.
Well, there is, but the volume, the numbers are in regulation, so that would require a regulatory change. I don't know that we built in. I think moving forward as we evaluate the programs, we might want to consider.
I would be surprised if it was in there, but it seems to me like something you ought to think about because there's not you, the collective.
Right. Well, and there are also cardiac procedures that have that don't necessarily, there's a definition of what we count as a cardiac procedure, and there's criteria that was developed. And so I think that we might want to consider changing that definition perhaps in terms of the volume, because what's happening as clinical advances, continue to improve, and as there's authority to have these procedures in a variety of different locations, the volume requirements are getting harder and harder to achieve.
We had,
There's a lot of, go ahead. Oh, I'm sorry.
we had a schedule for reviewing the different parts of the state health plan. When are these regulations up for review?
I'll look, but they were last revised in 2019, the last date. So they should be coming up.
Because I agree, we should be looking at the latest data when we do the regulations, but if it's actually changing faster than that, you might need an additional.
Right.
Because even, and not to beat it to death here, but there's going to be a lot of change that we can get data on that might impact this in related to, but not limited to volume.
Right.
So there might be some de-skilling involved as well.
Right, well, and it's less invasive procedures, replace, you know, these more open heart surgery, cracking the chest open. I think that that's what the programs are encountering, so. I think there's another, you know, as I was preparing this, I was, you know, in talking to MEMS, who designates the cardiac interventional centers. It seems as there is some overlap with what they do and what we do in terms of the reviews for the certificates of ongoing performance. And I know that Eileen has been meeting with MEMS, and they have been discussing how can we make it, at least for the facilities, eliminate the overlap. So, and that probably will require a revision to the regulations. So I think it's a good suggestion by the chair. We do need to start thinking about revising these.
Related question, then am I right? Did you say earlier that some of our oversight, when they report to us, they have to say that they have third parties coming and looking at what their programs, is that right?
If it's with focused reviews, yeah. So, and peer review.
Yeah.
So, yeah.
So there are three types of review. There's the internal peer review, there is the external peer review, and then there's one of the triggers, there's an MHCC initiated review called a focused review.
Right.
So they can start off with an internal peer review.
They have to do those periodically.
Is there any requirement that there's an external peer review?
Yes, for PCI.
Yeah, that's what I was getting, because it seems.
That they arrange for themselves. We know who their external peer reviewer is, but we don't dictate who they pick. Focused review, the MHCC arranges the reviewer.
I just recall at our last session, I think we had one or two people come before us that had some issues with the external review. So I just want
that was our reviewer that they had questions.
Yeah. Okay, next slide, please. And so the second issue that's developed is that CMS has now starting in 2020, they will reimburse PCI in an outpatient setting and ambulatory surgical centers. And that was in November of 2019 when they announced the rule, and that was implemented in 2020. So in order to do that in the state of Maryland, that would require a statutory change. So I know that there has been some conversations and some suggestions of, you know, what we were going to do about this and should there be legislation. But there are factors to consider. Primarily, we could look at what will the implications be in terms of PCI volumes at the hospitals that are currently performing these procedures. I think staffing, when I talked to the MEMS folks, you know, staffing, there is a shortage of interventionalists as well as cath lab nurses and cath lab techs. So it can compromise what's going on at the hospital. So I think this, you know, has to probably be carefully considered. And then like the next two slides simply walk through a lot of different factors to consider. But that's, you know, so we've evolved from, you know, but what's interesting to me, honestly, is that from 1980 to now, we only have 11 programs. And with the last two open heart surgery, and I think it's indicative of sort of the technological and medical advancements. So I don't know that we'll see more open heart surgery programs or cardiac surgery, I should say. But I think there are issues like the settings and what that does to the existing programs that we need to consider. And next slide, please.
Winnie, you said the cases of open heart surgery are declining. So are they including TAVR and other procedures to make 200 numbers, or those are separate?
Count TAVR.
Yeah, I don't think those procedures are included. And I think that was one of the, earlier comments is we need to look at the definition of what is considered cardiac surgery. off the top of my head, I know there's 4 criteria, and if you meet 2, you make your cardiac surgery, and I don't think TAVR is one of them that qualifies. So I think it's, again, another consideration as we look to update the regs.
Because in many hospitals,
PCI definition either.
I'm sorry?
TAVR doesn't meet the PCI definition either, does it?
No, I don't think so.
Does not.
in many hospitals, I think Capital Regional has a low.
Transaortic valve replacement.
Yeah.
Valve replacement.
Yeah.
Using a catheter to replace your heart valve.
So just, so the process would be, as we think about this, we have a very capable clinical advisory group that advises staff and indirectly the commission on the evolution of our oversight program. That would be the first step that we would take in moving some of these issues through a process where we would consider changes. So it's a somewhat more elaborate and engaged work group that has been with us. Some of people from the very start, others new, but this would be anchored on solid clinical input.
Right, and I think I can stop. I have other slides, but they're simply factors, so I don't, given the late hour, I don't think I need to go through those, but please call me if you have any questions.
Thank you.
Thank you.
Yeah, and I think the emphasis here that I want people to walk away from is that the key element of the reforms that the legislatures passed in 2012 was ongoing review, and internal, external, and then if things really go like are significant, the commission itself hires a reviewer, and I think it was a few exceptions that ongoing review has been really important, and I think there's recognition in the industry that that has been helpful. Secondarily, particularly as it relates to PCI, the ACC has been much more aggressive or ambitious in setting appropriateness standards. Although all of the operators that are participating in our CAG work group have said, there are going to be occasions when any even high quality interventionalist will go over and occasionally treat patients that are potentially not appropriate for PCI because it still is an art as opposed to a complete science. If someone never does a PCI intervention on a patient that another reviewer judges as questionable, they contend that operator is probably missing some that should have gotten it that didn't. So that's not anchored in science. It's been anchored in kind of the common assessment of the operators. But I think the ACC work has been very helpful.
I mean, and to that point, that when you had the previous issues that you mentioned about programs were said to have performed interventions that weren't appropriate. In those cases, there was some concern about standards changing, current standards being applied to procedures that were performed some years prior. So all of those variables move over time. Back to the issue of sort of keeping a look at, not just volumes, but what we do to say that programs are still
viable. Yeah. And the key operator who was head of the cardiac, the cath lab at St. Joe was also reviewing. Well, there was a review. He would window off his own cases, which was partially one of the problems that led to St. Joe.
That's why the questions about internal peer review and external peer review.
Bingo.
I mean, that case also triggered other legislation amongst state agencies to share information, because I think if HSC, maybe it was HSCRC data was shared with another agency, then you would have seen that the utilization rates were so off the chart And so there was, I think there was legislation that passed it that related to that as well.
There's several things that were wrong going on there, but you know, the main one to me was, so I was involved with a cath lab at another hospital. So when that was in the news, right? So the main thing was if you'd had any kind of external oversight, they would have picked up on some of this stuff, the higher volumes, and started digging into that. That was sort of a touchstone. So took some comfort in knowing that we had some external.
Gonna move us on to the next agenda.
Okay,
item.
thank you.
Even Commissioner Douglas is 4 o'clock time now. Here's optimistic.
Oh, well, fair to stay till 5. I told you we'll be here.
The last agenda item is a presentation, and I appreciate the engagement by the commission. Commissioner Douglas and I just had odds on when we would end the meeting, and he's more correct than I am.
Yes.
Key telehealth initiatives in 2023 legislative health studies update. SB 534, Preserve Telehealth Access Act of 2023, and HB 1148, Behavioral Health Care Treatment and Access. Justine Springer, Program Manager in the Division of Health Information Technology, will provide an overview of telehealth key initiatives and an update on the 2 studies. The presentation includes background information on MACC's telehealth initiatives and overviews the study requirements outlined in SB 534, the Preserve Telehealth Access Act of 2023, and HB 1148, the Behavioral Healthcare Treatment and Access Behavioral Health Model for Maryland. Justine, please proceed.
Thank you, Chairman and Commissioners. I'm happy to provide an update on the key telehealth initiatives and legislative studies underway. Next slide, please. These next 2 slides will provide some background on MHCC's telehealth work that has been ongoing for more than a decade. In 2013, the legislature tasked MHCC with convening a task force to study telehealth and strategies for increasing adoption. A final report released in 2014 outlined recommendations for telehealth use cases to guide implementation of select demonstration projects. Between 2014 and 2020, MHCC helped fund 17 innovative telehealth projects. Lessons learned were largely generalizable and helped advance telehealth implementation efforts, better practices, and policy development. The Telehealth Readiness Assessment Tool, or TRA tool, was developed to support practices in gauging readiness to implement or scale telehealth. The TRA tool consists of a self-assessment questionnaire that can be completed using an interactive web-based application. It includes guidance and resources across 5 key areas: core readiness, financial considerations, operations, staff engagement, and patient readiness. The release of the TRA tool in March of 2020 was timely with the onset of the COVID-19 public health emergency. The TRA tool has had over 7,000 visits since 2020 and has garnered international interest as well. Most recently, the state of Sao Paulo in Brazil requested to use the TRA tool as part of a 3-year project to advance digital transformation. In response to the COVID-19 public health emergency, MHCC expanded its telehealth initiatives to support providers and consumers with the rapid adoption of telehealth to ensure access to care. The Telehealth Virtual Resource Center is a webpage that provides technical assistance to practices with information on telehealth billing, vendor selection, best practices in virtual encounters, and telehealth liabilities and risk. The MHCC developed public service announcements that played on local radio stations and in giant food stores to build awareness of telehealth. One PSA was recorded by former Baltimore Orioles player Jim Palmer. Next slide, please. Staff convened a telehealth policy work group in 2020 at the request of stakeholders to discuss the expanded scope of telehealth and the permanency of certain policy changes beyond the public health emergency. There was general consensus among the work group that further study was needed to examine the effectiveness of telehealth compared to in-person visits. In 2021, the General Assembly passed legislation requiring MHCC to study the impact of expanded telehealth coverage and reimbursement. A final report in 2022 included 15 recommendations, one of which noted the need for more years of data to assess telehealth payment levels. In 2022, the Health and Government Operations Committee requested MHCC to conduct an interstate telehealth expansion study. This study scope aligned with legislation that had been withdrawn by bill sponsors during the session. A final report included statutory, regulatory, and policy-based recommendations that are important first steps to advance interstate telehealth in ways that build upon existing actions taken by health occupations boards. Next slide, please. Two bills passed by the General Assembly in 2023 tasked MHCC with conducting 2 additional telehealth studies. Both studies require MHCC to study and make recommendations regarding the delivery of healthcare services through telehealth, including payment parity for delivery of healthcare services through audiovisual and audio-only telehealth technologies. The study required by the Preserved Telehealth Access Act of 2023 will determine if it's more or less costly to deliver healthcare services using telehealth and whether delivery of healthcare services through telehealth requires more or less clinical time and intensity on the part of a healthcare provider. An analysis of data from the APCD will estimate percent of the in-person rate that should be reimbursed for services via telehealth. The other study required by the Behavioral Healthcare Treatment and Access Bill will benchmark reimbursements for private payers in Maryland Medicaid to the Medicare physician fee schedule. An analysis of data from the APCD will examine payment levels for somatic and behavioral healthcare services delivered via telehealth and in person to identify if there are aspects of telehealth that yield lower or greater value over use and the adequacy of reimbursement. Claims data from 2019 through 2023 will be used in the analysis, and findings will inform the debate on payment parity. Final reports with recommendations are due to the General Assembly in December of this year. Next slide, please. 2 requests for proposals were issued in October of 2023 to identify 1 or more contractors to complete the telehealth studies. A total of 12 vendors submitted proposals. Milliman was competitively selected to complete both studies, and there are different actuarial teams for each study. Next slide, please. The next 2 slides will highlight analysis activities underway. For the Preserved Telehealth Access Act of 2023, Milliman is completing a trend analysis of billing codes for telehealth and in-person visits. Select E&M codes will be analyzed to assess provider time and intensity in telehealth encounters, and findings will be shared with stakeholders and inform development of recommendations. Next slide, please. For the behavioral health study, Milliman is conducting an analysis of E&M codes billed by behavioral health and primary care providers to guide the development of a payment adequacy framework that benchmarks payer reimbursements to the Medicare physician fee schedule. Stakeholder feedback will be considered in drafting recommendations. As noted in the last bullet, MHCC is providing additional support to the legislation, including a behavioral health workforce assessment through participation on the Behavioral Healthcare Treatment and Access Commission. Next slide, please. We've been able to gain some preliminary observations based on the work completed so far. Notably, use of telehealth continues to decline since the COVID-19 surge, but remains higher than pre-pandemic levels, especially for behavioral health. While telehealth is generally viewed as positive, there is a preference for in-person care. Stakeholder views on the continuation of telehealth waivers are somewhat mixed. Audio only can be a critical access point to care for more vulnerable populations in certain situations. Consideration of potential guardrails may be needed to prevent overutilization of telephone-only encounters. Clinical time and intensity is generally comparable between audiovisual and in-person encounters, and further data analysis will better assess the impact of audio only. Reimbursement policies influence access to behavioral health providers. Notably, behavioral health services are largely delivered by non-physicians, with clinical social workers billing the largest share of E&M codes. Next slide, please. In the coming weeks, Milliman will complete the E&M codes analysis related to assessing time and intensity for select services related to the Preserved Telehealth Access Act of 2023. For the behavioral health study, Milliman will identify groupings of E&M codes to include in the payment adequacy framework. Stakeholder engagement for both studies will increase following the completion of the data analysis. Drafting of the reports is slated to begin in June, and staff anticipates presenting the draft for commission's consideration at the end of the summer. The reports must be submitted to the General Assembly by December 1st. Next slide, please. Lastly, I'd like to note that staff updates the website with information on the telehealth studies. The link to a dedicated webpage for the 2 studies required by the 2023 laws is included on this slide. Next slide, please. And that concludes my presentation. I'm happy to answer any questions.
Commissioner Blake?
Thank you for your presentation. I wonder, did the study also explore a hybrid model of telehealth? Listen as a model for like.
So the studies are only looking at services build. So it's only looking at telehealth and the codes. So it's looking for the modifiers for telehealth. So it's not looking at kind of like a bundle of services in that way.
But it's a good point because there are like, different therapies now where the telehealth is much more convenient for follow-ups to see if there's a problem that make people keep coming back into the office.
I think that's, more of an episode type analysis that we might consider, might be something that we put on the to-do list as well, because I don't think remote, only is going away, for behavioral health services in particular, but one of the impetus for this study was that the thought was that the federal government would end its telehealth waivers at the end of 2024. It looks now like, or end them or make them permanent, one or the other. It looks like they're going to continue them on a temporary basis for another several years. So the legislature, could opt to follow the same sort of strategy. I'm not sure. I don't know if David Sharp has anything observation.
Question, by the way. So it does look like there's a strong prevalence to continuation of what's going on at the Medicare level by CMS. So it could have an impact on what the legislature would choose to do in Maryland. As it relates to looking specifically at different models, what anecdotally we see in practices is that if you're a physician, you first start with audio visual, but sometimes you'll revert to doing audio only in the event that you have a communication failure. Something goes down, it's just faster. But there tends to be more gravitation to a model where it is audio visual if it's being used. But we're also finding the numbers, the use of telehealth continues to dwindle because it's not that it's not offered. Providers have adopted it. It's just that patients and providers, as just you mentioned, tend to lean more towards, I want to come in and see my doctor. I like it when my doctor examines me and I'm there. I feel more comfortable. So it's an alternative and it works in many situations. But what we're finding is that post-COVID, the numbers are still trying to find what the new norm is. We see this continual sort of sliding back.
Even in behavioral health.
So behavioral health is a little different than somatic. I don't think behavioral health is yet to figure out its full potential because the challenges of behavioral health, honestly, as a matter of opinion, more anecdotal, relies on reimbursement. Because the concern is that there's more behavioral health people that are out of network. So it's hard to differentiate, what's the impact, how's it work? Because it's just the utilization of it is different. And in some situations it works great for patients in the behavioral health setting. In others, it's not so good. So that's kind of an evolving landscape that trails the somatic a bit.
Any other questions? Thank you very much. Thank
So,
you.
David, this Dr. Bhandari.
Question.
So
Go ahead.
do you still need a video? Because I speak to many physicians, as you said, the numbers are going down. Many doctors say, I have only one patient a day or maybe 2 a week. Why should I pay for the video capability? Because they have to pay monthly charges. So which I agree. And so how do you really need a video, or they can just do the phone call if there is only few patients a week?
So, great question. So there's different viewpoints. So the way a lot of practices have structured it is that they have audio as the backup, but not necessarily the initial go-to means. Some practices, as Dr. Bandari, you've noted, are wanting to let go of the costs associated with maintaining the technology and use audio only. Today, it's still possible to do that under certain situations. So I think that's, again, evolving situation. There's small numbers of patients who really want to use the audiovisual. Some providers still continue to offer it, other practices don't. So it's not an easy kind of answer to say.
Depending on what you're doing too, right?
Thank you. Yeah, I have a patient in my office. He still has a flip phone. You know, he's 89 years old, retired veteran. He doesn't want to change.
It's an excellent mental health because he's got a flip phone instead of a iPhone.
Thank you.
Thank you very much. Excellent. All right, final one, agenda item 9. Nope. Sorry.
Just an update on what's happening.
Right, that's right, agenda item number 8. Would you like to share the
So,
upcoming activities?
After a hiatus of a couple months, we have a number of CON applications that we plan to bring to the commission in June. They include a nursing home CON and several programs from new programs for the University of Maryland. We have one regulation that's relatively straightforward that pertains to the update of our user fee regulations, which we're required to update every 4 years. And lastly, there is the Healthcare Commission has the responsibility of approving electronic advance directive providers. There's one in the state. We've made numerous efforts to get more repositories for advance directives active in the state. This is one area we haven't been very successful in, but we have one, mydirectives.com. They're linked to a requirement in order to connect to the CRISP statewide HIE. They must be recognized by the Healthcare Commission. So My Directives, which is one of the early innovators in this space, and the only one that's been willing to go through the accreditation process, will be back before the commission and will roll out what they've done. So the vision for electronic advance directives, how people are responding to them, and ultimately a decision on your part on whether My Directives can continue to serve as a repository for advance directives for Maryland patients. As many of you know, you can now put your advance directive documents in your EHR. We think there's a fair bit of that that's occurring already, and for the long term, as EHRs become more sophisticated and the use of patient portals becomes more widespread, my suspicion is that that's where the volume of advanced directive documents will reside, but probably not good in a shoebox underneath your bed. Well, but better than nothing at all, I suppose. So,
who are the reviewers for the CON applications?
These are not contested,
Okay.
so they are
Got it.
staff recommendations.
Yep.
There's no, they were published. Is that correct, Jean Marie? The nursing home CON was already published, and we had no comments, no requests for interested parties.
Waiting for comments, so.
Okay, we're waiting.
it's still be contested.
It still could be.
If it's not contested, we'll have it.
Okay. So stay tuned on that. We still may be reaching out to a commissioner to serve as a reviewer on that.
I would like for all the commissioners to have that opportunity. It was very worthwhile, but I don't necessarily want to gin up contested cases in order to do it.
see how it actually works.
Yeah.
Thank you all for your patience throughout the meeting. Very enjoyable lunchtime presentation. Mark is on tabs for next month. We'll also have Secretary Laura Herrera Scott. We'll work around what her schedule is like. It's my understanding she wants to present with the commission in public.
So that would be during the meeting time?
That would be doing it.
Great. With that, I'll take a motion to adjourn.
Motion to adjourn.
Second.
Have a good month.
That is that.
Good. Yeah, thank you, everyone. We are done. Thank you for the engagement.
Go have,
Yeah, you know, there we go. All right.
We don't ring the gavel.
It wasn't official, but.
I think I might have to reschedule my presentation.
Second.
Have a good one.